This conference will now be recorded.
Hello and welcome everyone. Dr. Ibrahim, congratulations, Dr. Arti, Dr. Farzana Dia, and Dr. Hafiza, Dr. Javera, and Dr. Mai, Dr. Nabila, and Dr. Shamim. How are you, everyone? You are welcome, okay, in our special session, okay, where we are going to guide you in how to pass this part 3 in the first attempt. It will be easy because I'm sure that you have a very good base of the knowledge. Okay, so will not be a problem at all. However, this is not the only thing that you need to pass this part 3, actually. So, you remember in part 2 preparation, the most important thing was practice questions. So, you get the ideas and you know how the examiner want to test you, how the examiner can twist a little bit in the scenario. However, there will be always like a keyword or a buzzword in the part 3. Okay, you will be tested in things that other than the things that you have been tested in part 2. Of course, they are testing your application of knowledge and your communication as well. Okay, so I will say here, okay, this is used to be the circuit in the live course. Okay, this was before the COVID time, okay, which is now turned to be an online circuit. Next exam, okay, the college is going to announce all the details. So if they have any intention to make it live, they will announce detail. If they are going to stick to the online in the next date, this is also will be announced. However, they promised that they will go to the live as soon as they can. Okay, anyway, we should be prepared because the base is the same. Okay, there's no different. You are sitting in front of the screen communicating with the patient. Okay, and in real life you are communicating with the patient. So if you ask me, the communication is easier, okay, in the real life exam. Okay, so how many questions are there? Actually, the question in part 3 is a task, so you have 14 tasks to be tested in. Okay, so what is the assessment, or how are they going to count the marks? Actually, we have 5 domains. So I know that this is very basic, but in order to focus our plan how to tackle this exam, we have to understand how they assess us, right? So we will be professional in gaining marks. So we have patient safety, communication with the patient and their relatives, communication with a colleague, which is the easiest one of them, information gathering, which mainly mean the history taking, and applied clinical knowledge. This is when you answer the examiner question or when you give the patient a plan of management. Okay, each task will take total 12 minutes, 10 minutes for the practice, okay, while you are with the examiner or with the patient, and 2 minutes for the preparation. We will also here, and my dear partner, Dr. Shreya, so we are going together, okay, to show you how to make the best use of the 2 minutes. Okay, so when you in the cubicle or in the station, you would be able to achieve the highest possible mark inside. Okay, so how many role play stations are there? They are usually 9. How many structured discussion? And the structured discussion, it's a case-based discussion, means that you are with your examiner acting as a consultant and you are the registrar, and they ask you questions about, for example, a case with post-operative complication, like the famous videos I have posted yesterday on the group, bladder injury. Okay, so the consultant is going to ask you about what are you going to do, immediate action, recognition, okay, of the injury, and management plan. Post-operative, what are you going to do, or what are you going to advise for this patient? This is, for example, okay, the question that the examiner can ask you. There is a special format of the structured discussion, which is the labor ward, okay, management. It's handover. It's like the daily, handover we do in hospitals when you give handover to your colleague, or take handover from the night team and you are in the morning, okay. And how are you going to be the leadership of this labor ward? How are you going to allocate the task and manage the patient? Which patient is your priority in management? Which patient you are going to run to her room immediately, and which patient can wait? Okay, so this is, you need to explain that to the examiner in systematic way. The pre-operative gynae list, this is another structured discussion which is nowadays fixed in the exam. So the examiner is going to discuss with you. We have like 3 to 4 cases, and pre-operatively, okay, please tell me, how are you going, okay, to prepare for this surgery? Okay, what are the things that you will put in your mind for this patient in the pre-operative, intraoperative, and post-operative phase? If there is any comments, any safety, any procedure or any investigation need to be done, you need to explain to the examiner, and you need to answer according what is asked. Okay, so another one is a teaching, okay, one of the special tasks that we have. And in the teaching, you are the teacher who is teaching a junior colleague, okay. So they are testing here actually your ability to be a teacher, okay, your ability to communicate with your junior, how you are going to reassure the junior, how are you going to explain in simple way, okay, and how are you going to advise not to be judgmental, and finally, okay, give a proper and a constructive feedback to the trainee. Okay, so this is how are you going to approach this exam. Most of the courses for the part 3, they focus on the simulated patient task. And yes, it's 9 stations that you will have in the exam, but I need you to understand, okay, that it's different. The approach for every station and every patient is different. So the patient who comes to you in acute condition, okay, so it will be, of course, a role play, a professional role play. So she will act like she is post-operative and she had a severe headache, for example, okay, and you need to take history from her, focused history and important information, and you need to do what is necessary for her. Very common that you will have in the exam, okay, patient who had lower abdominal pain and query ectopic, okay, so you have to check safety point. You have to check if the patient is feeling any dizziness, or she is lightheaded, or anything, if there is any pain, shoulder tip pain. Those things are very important in the approach for acute patient, okay. So some patient, you will ask the patient, okay, so I need you to lie down, okay, um, and we will start oxygen for you, and I'm going to call the nurses, and we'll take your vitals and put you on a monitor, okay. So you need to explain that this will not be a classic station. Another variety of the station is a patient comes to you in the outpatient, okay, so they are testing you in different location, okay. So the patient comes to you in the outpatient, like for example in the gynae clinic, okay, and the patient, he had the problem of PMS, okay, and you need to manage this patient, okay, taking a proper history from her, giving her advice, explain to her what is the management plan, okay, and close, okay, this consultation with the patient satisfied, okay, and the patient had all her concern being answered, okay, that's very important. And your job in this station is actually when you communicate with the patient, okay, you should be smart enough that you take, the patient cues and address their concern. This is how they will consider you a good doctor, okay? Otherwise, you will not be able, okay, to pass this station if the role player is not happy, okay, about you. So this looks like a lot of things and a different variety of questions or tasks, okay? So my advice to you guys from day one, try to find a study partner. A good thing about being in a course that you are already in a study group, okay, and you are already, okay, part of a study group to practice, so you can practice all the time. Practice in the session live, okay, or practice with your friends in the group. Study, practice, practice, practice with your friends, okay, and every time you practice, you will, you will be aware of what is the missing point of you, okay, and we will work together actually to improve your performance, okay, give you the tips on the way and tell you how to gain mark and pass this station, okay. um, this was my quick introduction, okay, for what are we going to do specifically, what is the plan for the course. Okay, I'll need also to explain because this is a question that I know everyone is thinking of. Okay, how are we going to achieve our goal? So we will have 10 weeks of intensive practice. Okay, that's mean 3 sessions in a week. One session mainly, this will be by dear Dr. Shreya, okay, and the other 2 sessions, this is for practice, okay, so you will be you will know what is the theme of each module and each task and how to approach that. This is will be the teaching part from our friends, our mentor, Dr. Shreya, okay, and then you will be with me, okay, in the practice. So in the practice of task, actually, you will be given the task in advance, okay, and what I will do is I will test every one of you, okay, whether you have achieved, okay, the all the tick points, or you have covered the domains of each station or not, and I will correct it to you, okay. So that will be like practice and correction of mistakes. So this is how the things actually will go. Our aim is to cover all the exam stations before. In part 1 or part 2, recalls are important, but not as much as important in part 3. Actually, in part 3, you can go to the exam and find the 14 station is previous exam questions or came before as they are, okay? So it's very important. So we will be covering that. There is also books to practice, okay, and videos to help you, okay, for the communication. I'm going to post you everything on the group, okay, and there will be like every week feedback, personal feedback for everyone. How are you going, okay, with your preparation? So you will be asked to be active, and it's required to pass this exam that you should be active, okay, in the course. The competition rate now is very high, okay, higher than ever, because actually people are, there's a big, backlog. This is because the COVID, okay, cancellation of part 3 exam, yet part 2 exam was continued, okay, so there is a lot of people there waiting, okay, actually the problem from even before the COVID, so people are there waiting to set the exam. So if you got the chance, make it, okay, in this chance and pass. This is the advice. So prepare well, okay, and study hard, so you will finish and you will be graduated, yes, and you will be member of the Royal College of Obstetrician and Gynecology, which is known as the highest certificate actually in our career. So this is how things are going for the week 1, which is started today. You will have the Urogynaecology, and Dr. Shreya is going to explain to you guys how to approach the cases, how to take history from the case, okay, from the role play, and she will give you her valuable feedback. Then session 2 and 3 will be practice recalls, okay? So I'm going to post to you what is the station that we are going to do it, okay, in the practice station. Your job is to prepare those station, so you don't know which one you are going to introduce. So what I'm going to do is, in the practice station, okay, I'm going to ask you guys, like for example, Dr. Farzana, please introduce case 1, Dr. Amr, please introduce case 2, like that, okay, and I will give you the feedback. No worries of making mistakes, no worries at all, okay? So don't worry, don't worry. It's the only way that we get perfect is to practice, practice, practice. Okay, so this week we have the urogynecology. Next week we have the surgery post-operative. Third week will be the oncology module. Fourth week will be the gynecology and subfertility. Week number 5 will be the antenatal care and early pregnancy complication. Week 6 for the maternal medicine, and then labor and delivery. Finally, we will have the reproductive health, postnatal problem, and sexual problem. We will have a mock circuit, like mock exam at the end of the course. Okay, so everyone will be tested, and this will be a very good practice before your exam. So I have finished my introduction. Thank you very much, guys, for listening to me. Hopefully that it was not so boring so far. And I'm going to leave you with Dr. Shreya.
Thank you, Dr. Rabba. I mean, you just, surpass yourself every day, I think. Such an angel for everybody, I'm sure, because it was a wonderful, wonderful way of when I had also been with you in this journey. So I'm sure everybody has got a very basic introduction about what to expect from the exam. So what we are going to do now is, as Dr. Abba said, we are going to start with urogynecology today. Unfortunately, I've been able to put together only 4 cases for today, but I'll be targeting to at least cover 5 in each session. So what we are going to do today is, we are going to try and discuss one important area each. Okay. So, and after that, we'll just discuss 4 cases and see if you have any queries with that. Okay.
I think it will not be a problem, Dr. Shreya, dear. If you discuss today 4 cases, actually, this will be fantastic and very informative. Don't worry, I will, do the stations in the practice, so we will not leave any. And anyway, the urogynecology is a very light module to start with. Okay, so hopefully it will be easy, guys.
Okay, just give me some time. I'll
Okay,
start
of course.
sharing.
Okay, of course, take your time. And guys, if you have any question for me, please don't hesitate to ask.
Okay, do let me know if you can see the screen clearly, please. Okay, so okay, we've been through the introductory part wonderfully. So this is what I think Dr. Rabah has given a wonderful slide here. This is about the basic questions. I think she has already shared with you in the Telegram group. So just, so that before we begin, we just quickly want to go through this, history taking, because one thing I would want each one who's going to appear, urogynecology is a very, very simple module actually. But the problem is it has got a long history taking. But if you are organized and, this should be on your fingertips. So it should not be that you have to think of what to ask. Okay. So this is going to help you. Just go through this. This is the way you ask. Okay. We cannot possibly ask frequency, urgency, or nocturia. No. So we are supposed to avoid medical jargon. That's a rule of the thumb for any part 3 exam. And whenever you're communicating with a patient, that is the number 1 rule. So so what do we do and how do we ask? So you see, we have some examples here. For example, you want to ask about frequency. So how many times do you need to go to the toilet? So very simple question, how many times? So that indicates frequency. Now, suppose you want to ask about urgency. So it's like, have you ever felt the need to rush to the toilet? Very simple, question. So have you experienced any leak while you rush? Or, sometimes you don't make it. So is there any leak? Okay. Do you need to wear pads? Okay. If the role player answers yes, unfortunately, I've been wearing pads. So may I know how many? Okay. So if you want to ask about nocturia, so it is about, does your bladder wake you? Does your water bag wake you at night? Is there any leaking while you're trying to exercise? So these are the various type of questions that you may use when you're trying to take a history for urogynecology. Okay, this the last part I would like you people to just go through. Please don't forget to ask about the amount and the type of drink that the woman has throughout the day, because tea and coffee is a very common habit, and of course you need to know this because of the nature of this module. The nature is that we have to ask about fizzy drinks, we have to ask about coffee, we have to ask about tea. So this is how it goes. So if you have gone through this, it will be easy for you when you are taking doing your history taking. Later on, I'll be discussing, after I think 1 or 2 cases, I'll be discussing about a few more tips of how to remember certain questions. So we are going to have that. Okay, so I think we are going to begin. So who's going to be doing the first case with me?
Yes, Dr. Shreya, I can join.
Okay, Shirley. Uh, I will just set your timer then and put on the question. Will that be fine?
Yeah, fine.
Yeah. Okay, just give me a moment.
Okay.
That's right. Okay. Okay,
In
so
all,
yes. Can you see the screen? Please tell me that much, because
yes,
I'm not sure if I'm doing it right. Okay. Okay, thank
yeah,
you.
I can see the screen.
Okay, okay. Yes, you had a question, please.
Oh yeah, I want to ask that in online system there is no, I mean there is nothing write any pad or any diary like that, because there
No,
is
you
no
cannot write, but you do have a system of typing. All right.
yeah
Okay, I think then I'll just tell you people about this as well, because Dr. Rabba did say that, you know, we are going to help you with how to use your 2 minutes. Okay. Now the problem
yeah
is, you know, from I would rather say from my experience, this may not be true for everybody, but the 2 minutes becomes very you know, tense as you go through the exam, because you know, you are so burdened with your last station, and then you are
mhm,
just going into the other station, so you really don't have time to think, right? So
yes
I would rather say it's the first thing before you step in is that please do not carry your previous station to your next station. Okay, it's easier said than done, but that is the first job. Don't think. Okay, if it is good, great. If it was moderate, okay. If it was bad, then also okay. Okay, so please, first and foremost, first job is because it eats up 30 seconds, so don't do that. Just forget what happened. Okay, now for the 2 minutes, when you're getting the question, you will require approximately I think 20 to 30 seconds to read a standard station, you know. But if you're given a prioritization or some bigger station, it's going to eat up more time. Okay, so you have a writing pad. So your job will be to make some notes while you type. Okay, you can type there. You are not allowed any pen and paper at all. You will have a
mm,
chaperone looking on that you're not using anything to scribble. Okay, so you have to
okay
and your hands have to be, you know, on your lap. You cannot have your hands anywhere else doing anything else. Okay, so this is the thing.
okay
So what I would suggest is that after you have read, okay, try to
mm,
make some points which
yeah
comes to your mind immediately. So suppose for example, this station, urinary incontinence, this is because I'm showing you this. But when you're having the question, you don't know what the station is about. But if you read the first 2 lines or 3 lines, you'll know I'm dealing with, for example, bladder pain syndrome, or perhaps I'm dealing with a stress urinary incontinence. So your
mm,
first job will be, what are the points which strike me immediately? I have to ask history, that is there. Then I have to think of some investigations I will tell her, and I have to think of a management, very simple, for any clinical case. So my job will be, whatever I forget, or maybe what is very important and I have to mention to pass, I write it down. Okay, so you
okay
use your own what should I say, short form in order to write. It will be individualized and it will be completely your own. You know, each candidate, I can write, for example, I should not forget in SUI, if I'm talking about for example, drugs, I should not forget a particular side effect of the drug. If I'm talking about a surgery, I should be mentioning particularly this about the surgery. So basically what I mean to say is your patient safety points. So please remember, because that is the one domain you have to pass. You have to pass. There is no option for you. Okay, so please remember what is there which I should not forget. Whatever comes to your mind, just type it in that small screen. So when you are doing your station, you can pull up that particular thing on the right hand or left hand corner, and you can leave it open, you know, while the role player is talking to you. So you can have a look
mm,
at whatever you have written. And if you're forgetting something, sometimes, you know, it helps to write down the order, because sometimes you forget, like, you know, you're tensed, you finish your history, you see you have no time, and you skip to management, but you forget a very important investigation. For example, you forget bladder diary, or for example, you forget urodynamics. Don't do that. Okay, so you write it down.
okay
If you remember any point, just bullet points, write it down, read it and tell it. Okay, so the
okay
good way of approaching your 2 minutes is whatever you feel and you have learned over all these months, you're going to just scribble it there. Okay.
okay okay thank you. Some people
Yes.
say that it will be take time if you write down in that time, so it will be
Yes, it will
wise to
take
take
time.
notes.
Yes. that is this is a problem which we had actually given as a feedback to the examiners as well, but unfortunately there is no other option, because their osler system which they are using, they do not it is a very friendly system, but that's why I
Yeah.
said you have to use your own method of short typing. It's called shorthand typing, and you would have to do that. And I would suggest, when you are practicing with us, okay, try to type
Yeah.
from now onwards, okay? But if it is an offline exam, then you will get a writing pad, don't worry. But if it is still online for May, I'm not sure. But if it is online, then it's you can start typing, and when you're practicing with us as well, or whenever you're practicing, I would suggest you take your laptop, just put a timer for yourself and start typing in 2 minutes, okay?
Yes. Yes. Okay. Thank you.
Okay, so okay, we move on to the first case then. The case will be on urinary incontinence. So I'll just put on your timer. There, your time begins. There is another page, so you tell me.
Okay. Change the slide, please.
Your time begins.
Okay. Okay. Hi there. I'm Dr. Farjana, one of the doctors in this Urogynaecology clinic. May I confirm your name and age, please?
Hello, doctor. I'm Samantha Scrivens, and I'm 45.
Is it okay if I call you Samantha?
Yeah, that's fine.
Okay. So Samantha, I have understood from your GP letter that you are having some problem in your water works, and you are came here to discuss about this. Am I right?
Yes.
Okay. Do you have any other concern and expectation from this consultation?
Well, I don't know. This is just too bad for me right now. So I'm too occupied with this problem. I really need help now.
Okay, I'm so sorry to hear about that. Okay, within next few minutes, I will be addressing all of your concern and management options. But before that, I would like to ask you a couple of questions to know more about your problem. Would that be okay for you?
Yeah, surely. Sure.
Okay, so Samantha, can you tell me about your complaint in a bit more in your own words?
Well, how do I start? It's now been, over 6 months really, that it's become very bad. I've been actually noticing this for the last 1 year or so. And, earlier it used to be just with the occasionally with cough or sneeze, I
Mhm.
just wet myself, but nowadays it's become so bad. I don't know, I'm so embarrassed, I just have to wear sanitary towels all the time that I'm going out. Okay, and how do I put it? I used to go for aerobic exercises, and I used to be very active, so uh, I think for the last 3 months or so, I've just been not able to do that. I've just stopped going, because it's become that bad. And I don't know. I think I've been going more frequently as well. I just seem to be going to the toilet all the time. So it's bad,
Yeah, I can see this must be distressing for you, but don't worry, we are here to help you and support in this situation. So, Samantha, okay. Can you tell me, since 1 year you are having this kind of symptom, uh, have you noticed any bulge or any vagina, any bleeding, any sort of pain?
No, bulge where down below?
Yeah.
No.
Okay. Uh, do you have any burning sensation during your menstruation?
Uh, During my what?
Yeah, during your pee, passing pee.
Oh, no, 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 it doesn't burn. No.
Okay, okay. Do you pee with effort or any difficulty?
No, I think I'm just leaking like a tap. I mean, no.
Oh, okay, okay, okay. Um, um, uh, any sort of is it affecting your quality of life?
Oh, yes. I mean, I actually work as a nurse, and
Mm-hmm.
it's been so difficult because we are always standing, so it's actually difficult. It's affecting my job, and as I said, I can't do the things that I used to do before. So
Okay,
it's
okay.
embarrassing. It's bad.
Yeah. So how many times do you need to go to the pee in day and night?
I believe I've been going more frequently. I've not really counted, but I think at night I do not wake up, no. But during the daytime, I think I'm going a bit more frequently.
Okay, okay. Can you tell me about your drinking habit? How many bottles of water or cup of coffee you take?
Um, I think I take about 4 cups of coffee a day, and
Mm-hmm.
water. Yes, I do. I do keep myself hydrated, but nowadays I've just I fear to take more water, because of this.
Mm, okay, okay. You also said that you mentioned you need to rush to the toilet, right?
No, I don't. I don't need
Do
to
you?
rush to the toilet.
Okay,
I'm just wetting myself. No.
okay, okay, okay. So, may I ask you some personal questions?
Yeah, sure.
Are you currently sexually active?
Yeah. Yes.
Okay. Do you have any problem during sex?
Yes. No, it's actually embarrassing, doctor. But yes, I do leak, even during sex, and I've just stopped, getting close with my husband because it's so embarrassing.
Yeah, okay. Yeah. So, have you tried something for this?
Not really.
Any treatment or any sort of exercise? Hello? 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 I can't hear you. Hello? Hello, Dr. Shrey, I can't hear you. Hello?
Hello. Am I? Yes. Can you hear me?
Hello? Yeah, now. Yeah, yeah, now is audible.
Okay.
Last
I'm
few
sorry.
seconds I didn't hear.
Yes. You may continue. No problem.
Okay. Uh, okay. Sexuality. Have you ever been pregnant before?
Yes, I have 3 kids.
Okay. How was the mode of delivery of your baby?
All were normal birth.
Mm-hmm. Okay. Do you know about the weight of your baby during childbirth of your baby?
Yes. The last one I would not forget. John was very heavy, and he
Mm-hmm.
weighed around 4.2 kilos, and they really struggled to take him out. I'd been pushing for ages, and I
Mm-hmm.
think they used a forceps, to pull him out.
Okay.
And
Okay.
but then that was some 20 years back. So it's okay.
Okay. Okay. I see. Can you tell me about your period?
Yeah, I do have regular periods, no issues.
Mm-hmm. Okay. Any pain or any bleeding in between your period?
No.
Okay. You have said that you are sexually active. So did you use any contraception?
Occasionally I used to use condoms.
Okay, that's fine. Are you up to date with your cervical smear?
Yes, I am.
Mm-hmm. Okay. Have you had been diagnosed with any medical condition in the past, like any chronic cough, like asthma or any diabetes mellitus or anything?
No.
Mm-hmm. Do you follow your GP any current disease apart from this problem?
No.
Okay. Are you taking on any medications right now?
No, nothing.
Any allergy from any medication?
No.
Okay. Any surgery in your tummy or down below?
No.
Okay. A few more questions about your social habit. Hope you don't mind. Do you smoke?
I'm not a smoker, but I used to smoke previously, yes, 10 cigarettes or so, but I've just, cut down now.
Okay, I appreciate that. Do you drink alcohol or any
Yes,
recreational drug?
I like my wine with my food every day, yes.
Okay. Okay. Tell me about your occupation. What do you do?
I told you I'm a nurse.
Okay, that's fine. What about your diet? What about your physical activity? Are you able to physical activity every day?
Yes, except for I had to leave my aerobics for this problem.
Okay. Are you aware of your height to weight ratio?
Yes, my doctor told me it's 36.
Okay. Have you ever thought to cut down your weight?
Yes, I did try, but didn't really help.
Okay, I see. Don't worry, we are talk to this problem later, and I will give you solution. What about your mood? I mean, in the last few weeks, have you feel down, depressed, or low?
Yes, because of this, yes.
Okay. If you want, I wish contact you a counselor and also the support group, and they will help you in this regard. Okay. Now Samantha, regarding your
Farzana, you have taken up your 10 minutes only with history.
I want to take
Okay.
1 minute more because some problem.
That
Okay,
is
no problem.
okay. You may continue. Let us at least go through the station a little bit. Okay. So I'll just stop the timer, but
Okay.
please continue with the
I will.
consultation because it will help to discuss.
Okay, I want
Okay.
to
But
take
but
two
yes,
minutes or 1 minute.
what I
Okay,
can
yeah.
suggest is, did you have a timer with you as well when we were doing the station?
No. Okay, I will
Yes.
put the
So
timer
now that
next
is
session.
something from today onwards. What I would suggest is, because it's very difficult. History taking is a problem which will stay till the end, and your target should be 4 minutes for Urogynec because it's a long history taking. but please put a
Yeah.
timer with you whenever you are starting a station, just like I am doing it, because I would make it look like a proper station exam scenario. But for you, it should be there so that you can keep an eye that how long am I prolonging the questions. Okay, so
Yeah.
try to speed up as soon as you see you're spending too much time on introduction or
Mm.
too much time on 2-3 questions. Okay,
Okay. Okay.
so
Okay.
we
Shall I
just finished
continue
the
or
station.
you
Yeah,
just?
yeah, surely,
Okay.
surely. Let us finish. Okay, come on.
Okay. Thank you. Okay. Samantha, from now regarding your condition, from what you have told and what we have done so far, you might have a condition we called stress urinary incontinence. Did you know about it? Anything?
No, I don't think I've heard of this.
Okay, let me explain for you. Actually, all our organs have supported and by some muscles and ligaments. But if it weakens either due to some repeated childbirth or some complications arise during delivery or some regarding menopause, though you are not in some condition, our support system may weaken, and that time there is a angle between your water work and water pipe, so this angle prevent leak. So this when these are supporting system weakens and the angle between water pipe and water bladder, it is straight and we become leak. This is the reason. Am I clear so far?
Yes, okay. And but why did I
Okay.
get this?
Sorry. Hello.
Why would I have this problem? Why are my muscles and ligaments weak? I mean, my friends are there, they don't seem to have this problem.
Okay, okay. There are, I have said to you, there are lots of reasons, like repeated childbirth, sometimes your hormonal imbalance, and this is could be the reason, and increasing age. These organs, like our water work and back passage may bulge, and this weakens due to the reason hormonal could be the reason. And in your case, so do you want me to know about your treatment option?
Yeah, yes, yes.
Okay. So there are something you can do for yourself, and there are something we can do for yourself. For as you are, if first of all you have to maintain a and maintain lifestyle modification. You need to cut down your weight. Sometimes it helps, and I that's why I will refer to the dietitian and exercise. Exercise program need to touch you exercise program, they will help you in this regard to cut down the your weight. And also you need to the supervised pelvic floor muscle exercise, where obviously a physiotherapist will guide you in, and it should be 8 contractions 3 times for 3 months. It will very helpful hopefully in your case. And another option is you have said that you are taking some caffeine and alcohol, and I will suggest please cut down these things, because this some irritant, this causes some irritants, irritate to the bladder. It would be better if you avoid those things. And also and if it's this simple measure will not improve your condition, then we will go further after our consultant and decision, and we will go to the further in surgery if needed. So I will give you a lot of information, and also I'll give you the patient information leaflet about this condition, so that you can go through it for your better understanding. And I will need to review after few weeks. Thank you for your time.
Thank you.
Hello.
Okay, so you did understand the main problem was, time management. Yes. Okay, that was first. And because you were rushing towards the end, I would rather say try to, while you are speaking about management, okay, try to involve the patient more. Okay. So,
right.
like, for example, you did ask that, so would you like me to tell you about how we treat you? Of course, she wants to know. That's why she's here. Okay. So when you are giving her options, you were very thorough with the lifestyle management. That was very good. But, you needed to elaborate more on the other options, particularly the surgery, because there are concerns in a role player when they are given a station. They will be having some questions. For example, if she is a candidate for surgery, you'll have a role player who doesn't want a surgery. So suppose you are dealing with somebody who is not a good candidate for surgery, you will find that the role player wants a surgery. Okay. So usually these are the tricky situations in the stations. And they are just trying to test you how, because applied knowledge is very good for all of you. You people have passed part 2, and it's wonderful. It's you know your material very well. But then what they're trying to see is how you're applying it in day-to-day life, and how you're applying it to your daily patients. Okay. And patients don't come as we want. They would come with a lot of difficult scenarios. Some patients will be easy, some patients will be angry. So you have to elicit what are they looking for. All right. So try to, whenever you're talking of management, your job should be stop after you've said something and ask. Okay. Ask that, okay, what do you think? Do you want me to tell you more about surgery? If she says yes, you go on. Okay. So this should be your generalized approach whenever it's not urogynec, it's any management. Okay.
Yeah, I stopped because of my time over. That's why I
That's
go
absolutely
further.
fine. But yes, now
But I
you have to work.
care of, definitely.
Yes.
I need to care
Okay.
of
So
assignments.
thank you very much, Dr. Farzana. We will discuss
Thank you
now.
for your valuable. Surely
Yes.
I will try to improve
Yeah,
myself.
sure. I'm sure you'll be able to do that. We are here to help, and we'll do it. We'll get there. Don't worry. Okay. So all of you here, you have an idea of stress urinary incontinence. I'm sure you know your guidelines well. So we'll just go through certain snippets which I wanted to share with you for a station of stress urinary incontinence or anything related to it. Okay. There will be varieties of station which are coming today. The 4 that I have chosen to discuss are only so that you get the basic and you can do any variant of station from here. Okay. So the first one about SUI is information gathering. Already the slide that I had shown you previously was wonderfully compiled. So you can just learn it up by heart so that it comes on your, just when you are saying it should come very spontaneously. Now, I just want you to remember this one part, that in every Urogynec station, please remember 5 points and learn it up. Because this is going to help you when you are in the stressful scenario of an exam. Okay. You don't have to try and recollect what I asked and what I didn't ask. Okay. So what are the 5 things I want all of you to remember? Would be bladder, bowel, prolapse, sexual, and aggravating relieving factors. Okay. If you divide it into these 5 headings, it's going to really help you to remember so many questions. So let's start with, for example, bladder. So whenever you're talking about bladder, there are 4 things which should come immediately to your mind. So one is, I will ask questions on stress urinary, that is, do you leak? Second is, I would ask questions about overactivity of the bladder, like frequency, urgency, nocturia, or urge incontinence. Third is, I will ask questions on voiding disorders. And fourth is, if there's any symptoms of UTI. So these 4 come under the broad heading of bladder. So please remember that if I ask about bladder, I'm going to ask all 4 in any Urogynec station. Okay. Because you never know if your station is a mixed incontinence. You never know if it is a somebody who is having a voiding problem. You never know if you are dealing with a patient who already has a running UTI, because if you miss that, you're missing a patient safety point, right? So please make sure that you remember to ask this. Apart from that, as I said, you ask about bowel, you ask about sexual. It's a routine signposted questions, whether there is any trouble in sexual life, partner reaction, etc. Prolapse is an important question, as well as mass in the abdomen. Okay, so these two come hand in hand. So you can just remember whether there is any lump in the tummy or any lump down below. Okay, bowel I asked because if you're dealing with a prolapse question, dealing with a posterior wall prolapse as well, so you will have the answers when you ask about bowel habits. Okay, sexual, as I have already mentioned, and aggravating relieving factors are very, very important, because you will have to know what the patient has to do in order to, for example, digitation. So if the patient has to do a digitation in case of a prolapsed mass in order to be able to micturate or able to defecate. So these are the broad, and this I've given it here so that it's going to help you in the next of the next of the 2-3 stations we have left. Okay, now coming to this particular station, as I'm not repeating this I've already said. So these are the questions you need to ask, already mentioned here. Now, any treatment done so far, Dr. Farzana did mention, so that was very good. So what have you done or tried so far? And if the patient does mention about pelvic floor exercises, please remember to ask two important things: whether she's doing it right, that is whether it is supervised or she's just doing it herself. You'll have role players who will tell you that yes, I just read it over the internet, or I had a friend who had been doing this and I just learned it from her. No, it has to be supervised, and it has to be a trained physiotherapist who's going to guide. Okay, apart from that, the duration. So if you remember from the guidelines as well, that for stress incontinence, we usually minimum of 3 months is what we would suggest. So that is very important. And apart from that, we go for the routine questions, which I think we have already discussed, the gynae questions. Yes, here I would like to ask you to remember, like this patient Samantha was 45-year-old, but she had regular menses. But you may have a case where the patient is perimenopausal or postmenopausal. Please remember, if your patient is postmenopausal, ask about HRT, or ask about, try to assess about the need of HRT, because you're dealing with a urogynecology station, because this will become very, very important, later on for your management as well. Obstetric history is very important, especially if you're dealing with a younger patient, somebody who's had a delivery, a heavyweight baby, somebody with a forceps, so that's why we need to ask about any instrument, maybe the birth weight of the baby, any complications at that time, because you will have some stations in urogynecology wherein one of the there must have been a tear, a very bad tear, or a anal sphincter problem, and with that has been repaired, and now the patient comes with a prolapse or comes with some other issues. So please ask of any complications faced during and after the forceps delivery, if at all there has been an instrumental delivery. So that becomes important, more so for younger age group who are presenting soon after, or had a recent childbirth or so. Now, medical issue, particularly this is asked in order to let the examiner know that you know. So as I was speaking of the aggravating and relieving factors, your management will be based on that. So if you are dealing with a patient who has asthma, you have to ask for the control of asthma, because if you do not control it, no matter what you are going to do, for example, you advise the patient for a surgery, but she is having a chronic cough. So it's not going to really help, because you are not addressing the main aggravating or the risk factor for this patient as well. So medical questions are important here. Surgery, mostly it will become important if the patient has had a previous continence surgery. So that makes it a bit more difficult, and you will have to change your management advice accordingly. Like there, you may have a scenario where a patient has come to you after she has had a tape surgery or a colposuspension. So if that is a scenario, it's a complicated one, usually doesn't come, but you should be prepared. So that is the importance of surgical questions here. Social, I think we have already discussed in the role play itself about the drinks and the BMI and the occupation. Now, occupation is important because if the patient is involved in anything to do with heavy weight lifting, you have to address that while you are managing her. Okay, so please don't forget, there are certain modules, and I would like you all to just mark and make a note for yourself, certain modules which have certain important history. Like one of the modules is Urogynaecology, wherein occupation, BMI, social history, actually overall medical history, these are very important. Okay, so please just mark for yourself, in those 2 minutes it should come to you spontaneously that these are the areas I would highlight because I'm dealing with a urogynec station. Okay, so occupation also plays an important role. Now, applied, you all know. So what I have tried to give here is how to approach. Okay, so suppose you want to explain the diagnosis of stress urinary incontinence. So Dr. Farzana did say very, very beautifully, and in fact, she had given a very extensive and a very nice explanation. So you may go for something like, when the muscles or the ligaments which are supporting our water bag, or maybe the neck or the opening of our water bag, when they become weak, then if there is a sudden extra pressure, and that is what we call stress, like a cough, or maybe you're sneezing, maybe you're laughing, maybe you're moving, so that time the water bag cannot stay closed and you may just leak. Okay, so this is a situation wherein we call it a stress urinary incontinence. So this you may just use it while you're trying to counsel. If the patient asks you why, you have your answer. This I would suggest, try to, whenever you're practicing a station, try to get at least 1 or 2 points in your mind as to why, because most of the role players do ask, why did I have this, or why did this happen? Okay, so please just 1 or 2 points so that you can tell. Now in this patient's case, she is BMI 36. She also had a forceps delivery. She's around perimenopause, so she had quite a number of risk factors, and you have to be able to tell that if the patient asks. Now, investigations should have been mentioned here. So, please remember the basic history taking, what we have learned in our medical school. I think all of us know this. So we ask history taking, we go to any relevant investigations, then we go to the treatment as such. So our management should not skip the investigations. So here the patient had a question and she said that I think I'm going more frequently than before. So please remember, even if there is no burning micturition, but the patient has some amounts of frequency, you have a doubt, you have to rule out any kind of urine infection. So a urine dipstick is a good idea until and unless it has already been done by the GP. So please, whatever is given in your role play, you have to go through that very, very keenly, because you should not repeat anything that is already given in your question. So if the GP has already examined, for example, and told you that this lady has stress urinary incontinence, then you need not repeat that. That is a form of respect for your colleague, and you cannot, or you should not rather, just override that. Yes, but you may require your own management, you may require additional investigations without trying to downplay the GP's role. So that can be easily done if you can just explain that I would just quickly want to run some tests for you, because that would just help us to clear out this diagnosis and make sure that we are not missing anything else. All right, so that may be a way you can just put that, why I would like to have some additional investigations as well. So please, here, I was waiting for the bladder diary, and please, bladder diary, if you think that there may be a chance of mixed incontinence, or some problem with urgency or frequency, please put the patient on a bladder diary so that you have an idea of how many times she's leaking, whether you're dealing with a mixed or an urgent incontinence also along with this. So, and if you are talking about a bladder diary, then explain to the patient what a bladder diary involves, and that is very important in communication with the patient. And also it is a very important part of your management. You have to explain that this is why we want you to keep a diary. okay, and how many days, what it involves. Just one line about that. Okay, if you're planning, for example, if the patient has a voiding disorder, you will advise for USG. If you think it is a mixed one, you don't know, or it's an urge predominant, you'll go for a urodynamics. If you think the patient is diabetic, or you think that the patient requires an investigation to for her blood sugars, then blood tests may be indicated. So these are your presence of mind when you are going through the question. You should be able to come up with what, and I think this should be very natural. We all are clinicians, and I'm sure you people are working. You do it in your everyday life. So whatever comes up, you're going to you can put it there, that I would like to rule this out. Okay. Now, after that, options we have already discussed, and this lifestyle options was very well told by Dr. Fazana. So, you can use certain language while you are trying to counsel the patient. For example, you can say that, Samantha, if you make small changes in your day-to-day life, it actually goes in a long way to relieve your symptoms. For example, you just told me that you're having 4 cups of coffee. So, just cutting down coffee, because coffee is an irritant, as was very beautifully said, that it is an irritant, and it can really cause this problem that you're facing. Whenever we are faced with a increased height to weight ratio, we generally advise some healthy eating habits. We advise some exercise, because we've seen that if you can lose weight, it can be very, very helpful for your particular condition. So I think if we work together, then just putting these small changes can really help you a lot, because I can see you're very distressed, and we'd like to help you here. Okay. So as regards as PFMT, as I said, supervised, please make sure that the patient is being supervised. And this was already mentioned, that it has to be 8 contractions 3 times daily. Usually we advise it for 12 weeks. And you have to keep in mind the success rate little bit about whatever you are suggesting. So if you're suggesting an exercise, usually in half of the cases it will be successful. So this is something you need to just keep in mind. As regards the surgery, okay, there has to be 3 options, and these have to be told. So you need to have 3 options in mind. One is colpo suspension, one is autologous sling, one is the tape surgery or the mid-urethral sling. So whenever, now this part, I would like you to again take a note, because this part is very, very important for passing a station with any surgical detail. Okay, and this is not purely for urogynecology. So please take a note whenever you are trying to describe a surgery. What are the things that come along with the surgery? So number 1, explain the surgery. Number 2, you need to say it's an open or a keyhole or a vaginal. Okay. Number 3, is it going to be, we'll locally numb you? Are you going to be put to sleep? Okay. Hospital stay, so you can say, Samantha, you can expect to stay, for example, 2 to 3 days. Usually the recovery is usually fine, and you may experience some vaginal bleeding, you may experience some pain, you may have some soreness in the wound area. Okay. But if you notice anything, for example, like you cannot pee, you're having to rush, then you please come back. So that is the complication. And usually we've seen that, for example, 8 out of 10 or 9 out of 10 surgeries are successful. And we can always say that this is a good surgery. For example, if it is colpo suspension, it can be 8 out of 10 success. If it is autologous sling, it's about 75% success. So please remember a basic, both for PFMT, which was 50 to 60%, and this as well. Part 3, you do not require to remember numbers, no, but you need to know at least just a generalized idea. So try to keep that in mind when you're counseling for any surgical station, and it's not exclusively for urogynec. Okay. So explain certain complications. This will be your patient safety point. You cannot afford to miss this. Okay. So certain complications, if you're counseling about colpo or you're counseling about sling or any tape surgery, please mention that usually there may be some voiding issues, there may be some problem where you may have to rush, there may be some infection, both in your water bag infection, it can be the wound infection, there may be some small chance of injury to the surrounding structures, there may be painful sex. no need to give it so extensively. I have written it just for your memory, but if you touch this point, it is more than enough. Okay, so don't put a pressure on yourself that I have to, oh my god, I did not mention dyspareunia, or I did not mention this. No, it is not required, and you won't even have that time. Okay, so please just touch this point. Now you have to mention bulking agents also. If you had asked me, this role player did not was not very happy with surgery, so she would have told you, doctor, you just told me about surgery, but I don't want a surgery. Is there any alternative for me? So you have to tell her that if you're wanting no surgery, then the only alternative would be a medicine or a bulking agent. So if it is, what is a bulking agent? Okay, so you have to explain this, how it is done, again put it in this pro forma. So it has to be like what it is, how it is done, whether you need to stay or it's an OPD procedure, and whether it is successful or not. Here one important point becomes is a repeat injection. Okay, so whenever we are dealing with the Botox injections, we're dealing with bulking agents, please remember that tell the patient it's not foolproof. You may have to come back. Okay, it stays in your body forever. These are certain terms, buzzwords, which you need to keep in mind when you are explaining these options. So somebody, if your scenario had been a younger woman, for example, she was a 35-year-old and she has a single kid, and if you ask her, she tells you, yes doctor, I think me and my husband, we are looking for two more kids. Okay, but she has a stress urinary incontinence, so of course this would not be a wonderful option for her. No, that time you have to either tell her that you complete your family, and then maybe we'll think of surgery. And if you're really looking for some management right now, we may help you with a bulking agent, etc. Okay, so this is something you need to keep in mind. Duloxetine, if you are mentioning at all that there's a medical second line for SUI as well, then you have to touch the side effect of the drug, and just touch. You may not have to say all 4 or 5 side effects, not required. Okay, but just touch that it's a tablet, but you may experience some side effects, like you may feel sick, you may have some tremor, etc. But then I'll talk more about it if you want. Okay, and lastly, HRT, again, this matters if you're dealing with a postmenopausal woman who's having urgency, frequency, and vaginal dryness below. So you'll have to touch this when you are answering. Okay, so communication, I think we have discussed this completely so far. So this I want to again reiterate this part to all of you here, that please ask what is her choice, please. So this is something, it is true for all stations. Okay, so please ask what would she like. Be very sensitive when you are counseling about body weight or lifestyle changes. Please remember, habits die hard. So if somebody is in a habit that is very difficult to change, and you just can't lecture somebody to, okay, just cut down and that's it. No, so be very sensitive when you're counseling, particularly if it is an obese patient for you. Okay, clear understanding of the options of surgery or alternative. Now this, I want you people to please take a note. Do not ask, am I clear, or did you follow so far? Do not do this simply because it is more like you are teaching. No, we are not teaching, we are having a conversation. So just have a conversation, and in a conversation, I'm sure all of you will agree, we do not ask, do we ask that, okay, did you follow? No, we don't ask that. Then what do? We just say that this is all about the surgery, so do you have any questions in mind, whatever I did discuss so far, or something comes up in your mind, please ask me, stop me and ask me. Okay, would you like to know about the alternative? And I would like you to know more about the risks of this operation, because as you know, each operation has some risk or the other, and this is a particular risk that you should bear in mind. So please, this should be your approach to counseling. This should be your approach to communicating with the patient. Do not be like a robot, because that is something which will only make you lose marks. Okay, now these two are common, so you know that, and all of us have to maintain this, giving a PIL. Regarding communication with colleagues for this SUI, this is the holy grail. Don't forget, every station, consultant. I will ask my consultant, until and unless in your case it is given that you're the consultant. Otherwise, you have to ask for your consultant. call in the physiotherapist for the pelvic muscle floor training. You have to discuss referral, particularly if you are dealing with, you're planning for a surgery for the patient, then you have to rope in the urogynecologist. If you're planning for a bladder diary, you have to give, her a continence advisor. Usually a continence nurse is assigned to the patient, and the nurse's job is to advise her how to maintain a diary. She will tell her about how to do the about various ways in which she can control her urge. Usually this is more important when it comes to OAB patients or overactive bladder patients. Okay, so MDT comes in before surgery. Now this is again, if it is appropriate to your station, if you think that the patient will require HRT or a further discussion on HRT, then you may have to refer her to menopause clinic, and the GP cannot escape because the GP has referred to you. So you have to write back to the GP as to what you have done for the patient and what is the management plan in your mind. Okay, patient safety points, we all are aware. So I would just like to reiterate this line. Please open and honest about the risk and recurrences whenever we are dealing with surgical management. If you're dealing with drugs, please mention one line about side effects, and tape surgery. Now here in urogynecology, mesh is an issue. Mesh complications is a bigger issue. So we need to address that whenever we are, anywhere there is a question of a mesh or question of a permanent suture. Please make sure that you should be aware of the safety issues related to that. Okay, documentation as usual is always important. Okay, so I think I'm done with my thing. Anybody would have any question? Otherwise we'll move on to the next.
Hello, Dr. Shreya. I have one question.
Yes, surely.
Yeah, how will you say the surgical option in layman terms, like colposuspension, rectal sling? That's why I just avoid those things. How to
Okay.
explain in a layman term?
It is. I would suggest, and I think we'll put in the PILs also for you to go through. The best way
Okay.
to learn about how to speak is to go through the PIL. Okay, and let me tell you, the patient information leaflet
Yes.
describes the surgery beautifully. So make a note for yourself. Write down one or two lines about the surgery, and that should be, learn it up. That should be your way of putting it. So for example, you want to explain colposuspension, so you can just say that we lift up the tissue around the neck of your water bag. Okay, and we kind of suspend it or tie it with strong stitches to a ligament inside your pelvis. Okay, so this
Okay.
is how you would have gone for a birch suspension. So don't rush, be very clear, and be slow when you're trying to explain. So suppose you want to explain a sling. So you can just say that sometimes, because as I said, that your water pipe area, your the neck of the water bag is weak. So what we try to do is we try with the surgery to give some support to that area, and that support is sometimes done either with a synthetic material, which we call as a mesh, or we may do it with tissue from your own body, which we call as autologous sling. Now these are medical terms, but the whole idea is giving the support to the water pipe from underneath, like a hammock. So a patient would understand and appreciate a hammock. So you can just say that we just lift up that area, such that once your surgery is done, whenever there is any cough, or you sneeze or you laugh, even if there is a stress, it helps the water pipe neck to stay close. Okay, so something like that.
Okay.
Okay, Dr. Javeria had a question, can we draw pictures? Yes. Now
Thank
this
you.
I would yeah, well, you're welcome. So now this, in online exam, please remember, do not say let me draw for you. Please do not say that, because when you will be going for the exam in online, before that you are given a preamble by one of the examiners, and they do tell you that all the case scenarios given in online are video conferences, and they know, the role players know they're talking to you over the computer, and you're not sitting in front of them physically. Okay, so no examination at all, and no I can draw it for you. Of course, if you're having an offline, then it is the best way to explain to the patient. So if you're having it a live or a offline, please say that I will draw it for you, But if you're having an online, unfortunately, do not mention that. Try to explain as much as possible with your, with simple language only. Okay. All right. So, okay. So we will move on to the next one. Who is going to attempt the next station?
I would like
Yes,
to
I'm going to attempt.
Okay. Okay. That's great. So I'll just give me some time while I set the timer. I'll put your question on. All right, we will be discussing about mesh complication in this. So are you ready? Then I'll put on the timer with the question.
Yes, I'm ready.
Okay, 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 your time starts. There's another paper, so you can ask for that. Your time starts.
Uh, okay. Hello, I'm Dr. Javeria, one of the doctor in Gynae clinic today. May I confirm your age and name, please?
Hello, doctor. I'm Sarah McDonald, and I'm 59 years old.
Okay, Sarah, how are you today now?
Yes, I'm fine, doctor. Thank you.
Sarah, I have come to know about your case from your notes, from your case summary, that you have undergone a surgery 6 weeks back. Is that okay? Is that right?
Yeah, yes, doctor. Yeah.
And you have been referred for some problem you're facing. Is that right?
I don't have any problem. I was just called for a follow-up visit today.
Okay, you feel perfectly fine after surgery?
Yes, and I've been so happy, since the surgery. So I'm doing well. Yeah.
Okay, the complaint you had having before of leaking of your urine, is that settled now?
Oh yes, wonderfully. I was so happy with the surgery, and I really believe that it had been a complete success. Nothing, and I'm just so relaxed and so relieved after the surgery. Yeah.
Okay, I'm happy to know that. Sarah, you have been referred to us because in your follow-up, they found some some erosion in your at the site of your surgery. So for that reason, I need to ask you some questions regarding your surgery and your and your post surgery period. Is that okay?
Uh, uh,
Can I ask you
I'm
questions?
sorry. What what did they find? What is an erosion? What I was not told about anything.
Okay, I will explain you that in a moment. But let me first ask you a few questions so that I can have a better understanding of your problem. Can you please tell me that after surgery you have any problem in passing urine, any pain or any burning while peeing?
No.
Okay, and are you sexually active?
Well, actually, I just recently met someone, and I have been in a new relationship, and so actually, it's embarrassing. But then I thought that we might get into a physical relation very soon. So that was the reason why I got myself operated, because I just, it's so embarrassing like that. So well, I haven't we haven't yet had sex, but then but we pretty soon, maybe we may start.
Oh, okay, okay. Please don't mind, Sarah. These are questions we ask everybody. So I hope you will understand that in order to understand your problem, we have to ask these questions. Were you in any relationship before?
Yes, actually, I separated from my husband a year back. So before that, before the divorce, I was with my husband. Yeah.
Okay, and was that ever painful for you? Was having sexual intercourse painful for you?
No, never.
Okay, and let me confirm that after surgery you never had any intercourse. Is that right?
Yes, that's right.
Okay, and you have no problems in your passing urine and any burning, any pain,
No, nothing. I've been perfectly fine.
and okay, that's great. And your blood sugar levels have been controlled in this
Yes.
post-surgery period.
I am on some tablet called metformin. Is that right? And
Yes, yes.
I've been doing pretty well with that, because I had my blood tests recently, and I met my doctor as well. So he's very happy with my control.
Okay, and what were your physical activities in your post-surgery periods? Were you mobile? Were you taking walks or doing any exercises?
Exercise, no. But yes, I've been going about my daily job, and I think it's okay.
Okay, and did you run any fever in this post-surgery period?
No.
Okay. Sarah, please tell me about your social habits. Do you smoke or do you drink alcohol or any recreational drugs you use?
No, not really. Alcohol, yes, occasionally, but I'm not a regular drinker.
Okay, Sarah, are you allergic to any medicine or anything?
No.
Okay. Have you had any surgery before this surgery in your tummy or lower down before?
No.
Okay. Did you know the details of your surgery and your which doctor has done it and where it was done, in which hospital, and what was the type of mesh that was used? Did they give you any details about that?
They did told me that they're going to put a tape, a mesh, to kind of support down below. And Dr. Jackson had been very helpful. He saw me through, and he's a wonderful doctor. And I just had it in the hospital here. I think you have my discharge summary with you. So
Yes, yes.
that is all I am aware of. Yes, I have a tape inside. They told me. Yeah.
Yes, yes. Okay, Sarah, when you have come up for the follow-up, the doctor has examined you and they have found out that the tape they have put in your vagina to support your uterus, that is a little, eroded. Erosion actually means that it has been a little come out of the skin of your vaginal skin, and it's a very small, a 5 mm of size. A 5 mm is a very small size. In that case, we are not that much worried, but we need to keep an eye on it, because we need to see that if it's not it comes out more or not. That's our main concern, because if the area it's only 5 mm now, but if it's increased, then we need to be more careful. For a very small area like 5 mm, we need to keep an eye on it, and we will advise you some local creams to help you in this, and we will send you a urine test also to make sure that you don't run any urine infection. Is that okay?
So why do you think, I mean, I really believe that this was a complete success. Okay, so why do you think my tape got this exposed, you said? So do you think there was any problem with my operation that caused this?
No, actually, it is a known complication of this mesh surgery, and there has been a long discussion amongst the groups, amongst the surgeons, that either we should continue with these mesh surgeries or not. And for some time, this has been withheld also, and that's why we have made a whole body of governance for it. Also, it is called MEHRA, in which all the complications related to mesh are reported, so that we can keep a follow-up of all the patients which we have been placed with the mesh, and see what the complications they can get and how frequently these complications rise. So in your case, this is also a small complication which has occurred, and it is just because the tape, it exerts some pressure on the tissue and it makes a way out. Do you understand? Are you getting that? It's just
Yes.
the pressure which
So
is it is putting on the. Yes.
you did mention a cream which I need to apply. So I mean, if the cream doesn't work, do I need another surgery?
That depends on the erosion. For example, if it's constantly increasing in size, for example, we will let you apply cream for some time, and then we will again ask you to follow up with us, and we will examine you again and see whether this erosion has remained the same, it has decreased, or it has increased. And then we will discuss this case with other doctors also, involving my seniors, my consultant, and urologist, and we will make a plan that how we can help you better. But if it is
Okay.
in the most cases, with just simple cream, it responds.
Okay. So you say that there's a chance that I may leak again in future?
That's only if this erosion and this small hole, it enlarges and it makes a track with your water bag. In that case, you can have this problem. Otherwise, this gets sealed on its own with the help of cream, and you become completely okay. The only thing is that we need to keep an eye on you, and we need some follow-ups. That's the main point.
Okay.
Also, I will ask you
Oh,
to avoid.
unfortunately, time is over. Okay.
Okay.
Just yeah. So, what do you think? How was it?
I think I'm not that much okay with this. I'm not satisfied with my performance. I would
No, sir.
have
I
because
think you have done you've done a very good job actually. Uh,
no, because a
because
mash complication I was not expecting. I
yes,
remember
actually,
only few things about it.
no, but
I
for that
remembered
you have done
Mera.
wonderfully well. No, you've done wonderfully well. But the only thing is that mesh complications only, may come. This is a Lisa Joel station, so it's a very common old RCOG book station. So, I put it here so that we keep in touch with the mesh complications as well, because nobody is going to give you a station of consent taking for mesh any longer, But because we are dealing with
Yes.
colposuspension, sorry, I'm sorry, sacrocolpopexy, or we are dealing with TVT, you may have, patients coming to you after the surgery for with some kind of complications. complication or on a follow-up visit. So this can be you know, a common station for you as well. So you've done well, not bad. But you know, because you did mention something about making a tract. So it just struck me at the very end. So why do you think you mentioned a VVF or a RVF here to her?
Yeah, I understood that it was the wrong information actually,
It's not
because
wrong
it
actually.
it cannot it cannot yes, it can happen, but it's very unlikely that, you know, she would
Yes,
have a
yes.
long erosion for that long unnoticed. It goes
Yes,
unnoticed. It
very
is
exactly.
unlikely.
That was my point. Why because you know, it can be very frightening and daunting to the patient as well. So but you know, what was good is you have given something which is very rare, but it is yes, it is rare. Okay. So we will go on to discuss. You have covered most of the points. I have marked here, you know, whatever you have covered. In fact, you have covered most of the points. A few are missing, which I will just go through. Okay. So just stay with me. I'm going to just
Yes.
go through a few points. Okay. So it was not bad at all. It was good. Okay.
Actually, in my mind, it was always that MASH is withheld for some time in UK now, and they are
Mhm.
not doing these surgeries. So you know, MASH and its complication were like very deep in my mind. I had to,
Yes.
like, you know, think and drag and
Be prepared for a station, particularly after sacrocolpopexy. Okay. So you will, and you know, it's a very probable area for your examination also to come, that you know, patient comes to you for a follow-up visit after sacrocolpopexy more than a TVT. Okay. So that may be a very good station. And mesh complications also, because you know what has happened now with RCOG is that because the mesh surgeries have been done a few years back, usually whatever patients they are getting are the complication patients. They are no longer you know, getting
new
patients
patient.
wherein you're counseling as such for TBT, but you will get more of patients who've already undergone a surgery. Okay. So be prepared and have you know what, but you have had quite a good knowledge, so I'm you know, there's no problem. It was good. Okay.
Thank you.
So okay, so we do discuss about information gathering. So very nicely, I have you know, I have actually ticked. You have mostly asked the questions, so they were fine. A few questions which are very particular to the mesh are extra. I have already discussed, so this I'm not going to repeat anymore. What was good from Dr. Javeria was she did ask what is her current symptom. She did ask how did you recover. Okay, whether you did have any new symptoms like burning, like any problem to pee, or you're holding your pee, whether you have to rush. So these are very good questions, and these are common questions you may ask after any continence surgery. Okay. And mesh complication questions are a bit different. So if it is a TVT you're dealing with, your mesh complications may come in form of vaginal discharge. There may be some pain which is radiating maybe to the tummy, to the groin, to the you know, to the legs or something like that. Okay. If you're dealing with a sacrocolpopexy, then your questions become a bit more detailed. So, you know, pain inside, pain towards the back, pain in the buttocks. So these are certain questions which come with where the mesh is being put. Okay. Vaginal discharge is more common with the TVT because, of course, you know, because of the mesh exposure or the mesh extrusion. Okay, so these are the questions that we may ask about the history of present illness and the recent surgery that the patient has. Okay, so about sexual problem, very well asked, and that's why I appreciate that whether the patient has resumed her sexual life after the surgery. Because if you recall, and if you go through, and I would like you all to just go through once to you know, through the mesh complications. It is there in strategy. You can also read about it from the our NICE guideline. So please remember to you know, it is actually one of the safety advice you give the patient after a surgery to avoid sexual intercourse for a particular period of time. So that is mainly done in order to you know, prevent infection and complications, mesh complications. So sexual whether there has been any resuming of sex is a very important question. Any bowel problem usually is when you are you know, doing a sacrocolpopexy that involves a bowel problem. But yes, in long-standing cases wherein there may be a fistula, there may be a problem in the bowel from TVT as well. Okay, so this can just be touched, so no problem. If the patient has something to tell you, she will tell you if you just ask. That's all. Okay, details of the surgery, why the surgery was done. So here your patient did say she was very embarrassed and she wanted to resume her sexual life, and she was getting troubled with the incontinence. That's why she opted for the surgery. So why the surgery was done is just to get an idea whether there was any complications during the surgery. And this question is something, it's if it will be good if you can remember, that is during your surgery or during your hospital stay, do you remember having been given any course of antibiotics? Because if there has been a course of antibiotics at that point of time, that means there was an infection immediately after, and it might have been one of the reasons for the mesh complications. Okay, so this is about the details of surgery, and the rest of it, rest is routine. Gynae and obs history is usually routine, but I would have liked it better with this, that is, if the woman is menopausal, then in our case she was 59, so you have to ask about any menopausal signs, symptoms. Okay, and if you're dealing with a younger woman who has undergone a tape surgery or undergone a continence surgery, please ask about the future obs plan. Okay, because most of the younger patients, you will have role players with they'll tell you that I want to have more children in future, so that changes your plan of management. I have already discussed this in the last station also, so this becomes very important. So just depending on your question, you can change your history taking. So from medical, very well asked, how was the control of sugar, any allergy, any risk aggravating factor? This we have already discussed, as with any other station. Social, again, it is very, very important because you need to know whether the aggravating factor is still there or not, or whether any risk factor is still there or not. And what is the support like in home, because she's just undergone an operation, so support is also something you can touch on, because that just increases your marks in communication with the patient. That how you've been doing, do you have enough support at home, you've just had an operation, so something like that. If you can just touch that, it's a very good way of approaching somebody, especially if your visit is a follow-up surgery visit. Okay, and you can generalize this, extrapolate this, and apply this to any other surgical station. Okay, so applied knowledge, I don't think she has missed anything. It was good. She has explained the diagnosis of mesh complication. Again, our fundamental here would be to avoid medical jargons, and we would try to make it as easy as possible for the patient to understand. So please avoid what when you first approached, like this patient did not have an idea about why she is here. She was very, very happy with her operation results. So before you give her that piece of information that okay, we are not as happy as we are supposed to be because we've seen a complication now, so that has to be put forward to the patient. So when you get the vibe from the patient that okay, the patient is very happy and she's not really aware, so you change your approach. You change your approach of how to gently put it in her mind that actually you have been examined and this is your follow-up visit. I'm very glad you're not having any more symptoms. That's a wonderful thing. But unfortunately, we have found something, and we are not very happy with the results like we had expected. It is something that we had not expected, but then this has happened, and this is the situation, and you can explain in your own language that this is what has happened. If she does ask you, and mostly she will ask you that why I'm so fine, why did this happen, and you have told it very correctly put that yes, it is a known complication, and there are some additive factors in your case which might have caused it. Now in this woman, she is postmenopausal, so postmenopausal vaginal tissue does not have a very great blood supply. Okay, somebody who is diabetic may not have a very great and good vascularity. down there. So these may be, some factors which might have caused the mesh complication in this particular woman. So you just have to see if any reason for complication is provided to you, or if anything you can elicit from your history taking. All right. Now, something I have put here is a problem that many of us may face. Sometimes when we are trying to explain, we cannot keep our hands in control. So sometimes we move our hands. And, this is something you need to avoid, particularly if you are on an online examination. Do not try to make hand gestures trying to show mesh extrusion, a small area, or it has come out or something like that. Avoid any hand movement, because that does not go down well with the examiner or the role player. Okay, if it is an offline, as I think someone asked, if it is an offline, you may offer to draw and explain. So this will depend on what kind of examination you. Even in on live examinations, I would still suggest keep your hands to yourself. Do not move your hands so much. It is not a good one. Okay, so this is something I wanted to add here. And one more thing I wanted to add was that before you jump or try to explain for any management, please mention if you need any investigations and why you need the investigation. Why I would like to tell you this is, again, this particular thing I put here is for all stations. It's not urogynecology alone. Suppose you want this patient to undergo a dipstick, you want her to undergo urodynamics, you want her to undergo MRI, you say why you want that. Okay, so by doing this, you explain to the examiner, you have a very clear knowledge about what you're thinking. What is the station? What is your diagnosis, your provisional diagnosis? And it goes down very well with the with the patient. You just imagine your real life scenario. Obviously, if you just write down 100 investigations to the patient would ask why, instead of going to the treatment, you're again making me come back to you with so many investigations. What's the purpose? So you have to just touch that, as you said, you have some trouble. For example, if the patient has any feature of urinary tract infection, then I need to do a culture sensitivity. If the patient has any voiding issues, I would like to do an ultrasound. Or if I believe that the tape has gone somewhere, or there is an infection vaginally, a transvaginal ultrasound is a very good way of knowing that. I have put here MRI because if you're dealing with a sacrocolpopexy, and if you think there is an infection inside the pelvis, an MRI is a better mode of investigation rather than an ultrasound, in order to look for an infected mesh. Or if you think that the mesh has eroded inside, again, an MRI is a good test. Okay, urodynamics if you're dealing with overactive bladder features. So all this patient was a diabetic. So if you think that the patient was not well controlled, you would like to see her control, then you may advise for this. So these are all your presence of mind, and these are again what you need to jot down in those 2 minutes. Just write 1 or 2 lines so that you don't forget it. Okay, that okay, I have to mention this patient, it's been given here, so I have to mention ultrasound, or I have to mention blood sugar. Okay, so you will not forget, and once you start saying, you will see, you get comfortable, you will be able to say whatever investigations you need. Okay, now again, always give all options, and I mean all. Don't only stick to the expectant management. Like in this case, it was a very small area, correctly said, it was a 5 millimeter very small area. But does that mean that she is precluded from surgery? No. She might land up in surgery if it doesn't work. She might land up in surgery if it expands, very correctly said. She might require it if it extrudes. So your options should be very clear and very extensive. So you say that yes, we have 2 options, and in your case, the option will not be a surgery right now, and you give your reasons. Okay, so you say it's a small area, like you said, it's a single area, not a multiple area. And you know what we are going to do is we are going to work together so that we can, you said that your sugars are very well controlled. That's a wonderful thing. So we'll just recheck that, and you continue the good work. So this is going to help. I'm going to give you a cream, like you said. And what is this cream all about? You need to just touch one line that it's a female hormone. It kind of increases the blood supply to the area. It helps in healing. Okay, and healing well. But this patient was, she did say that she has an intention to resume sexual activity soon after. Okay, but this is something that you have to tell her that, because we face this complication now, it is advisable to avoid sexual intercourse till your treatment time is over, because it can only increase your chances of infection, and we don't want that. Okay. Then losing weight if the patient has a higher BMI, because that has nothing to do with mesh, but as you all are aware, a high BMI does have a risk factor. It's a risk factor for stress urinary incontinence as well. So this will anyway a generalized treatment. So surgery, you have to touch and you have to say that if we are looking at surgery, what it means. It means maybe sometimes we may have to remove that particular area, remove a particular bit, try to remove the whole thing, but unfortunately the whole mesh cannot be removed. Okay. And if we are looking at surgery, you may land up at having recurrence of your symptoms which were originally there, and this will happen only after a, please don't mention MDT. Don't mention the word MDT when you are counseling a patient. It should be a team of doctors, and that's it. Okay, so we will be a team of doctors, and it will be at a specialized center. All right, so this is how you would have given your applied. And regarding communication with patients and family, first and foremost, I was looking for this, because this was given in your question. So please, I would advise all of you, read your case scenario. Okay, if in your case scenario it is given that there has been missing case notes, okay, I would like you all to address that in one line. Okay, Sarah, I'm sorry, we do not have your case notes here, but I do have your discharge summary. But then I would like to ask you a few questions because of, I cannot go through your case notes. I apologize for that, but would it be okay if I can just ask you a few of questions for your background history, so something like that. Just one line, just to apologize, because this is not expected, right? We are not supposed to lose the case notes for any patient as such. Okay, so now you have to elicit the patient's expectation, what she thinks of her condition. This was the reason why I did tell you, because the role player here, she was very happy, she was unaware. So please, I have already mentioned this, and you can just put in one line, because that what you're dealing with. You're dealing with a mesh complication, and it's once it's started, it may heal, it may not. So you have to, because she thought that it's perfect and nothing is going to go wrong, but that's not the scenario. So you may have to just tell her that, unfortunately, because this has happened, would you like me to discuss it with you? Do you want anybody to be with you? But please remember, this is not a breaking bad news. Okay, the tone may sound as if I'm asking for a friend, maybe, that would you like a friend or a family to sit with you while we discuss about the mesh complications. That is not a breaking bad news. So just stop there. You may ask for a friend, you may ask or may not, depending on the demeanor of the role player. So please be very active when you are seeing your role player's expression. Please look at her expressions. If she starts looking very distressed, she's very uncomfortable, uneasy, she's shifting in her chair, and you can see that, mind you, so if she's shifting in her chairs, her eyes are moving about, she's frowning, then please offer, stop and offer, would you want me to discuss it now? Would you like somebody to be with you while we discuss? I can understand I'm not giving you a very happy news. You were very comfortable with the surgery, and what I'm about to tell you, or what I'm telling you, is is not so happy. So if that is so, you can ask for somebody. Okay, but don't make it like it's like a breaking bad news. No. Okay, the next is what to expect. Don't tell her, because if you tell her that I'm going to give you a cream and it's going to be absolutely fine, no, that is not a correct information. So please make sure that the patient is aware. Okay, no sound. Am I audible or not?
Yes,
Yes,
you're
Am I
yes,
audible?
audible.
Okay,
Yes,
okay,
yes,
okay.
you
audible.
are.
Fine. Okay, so just to ask that this is the issue, and it may go either way. So we'll just follow you up. Let's see, and let's hope for the best that how it happens. And what are the red flag signs? Because we all read about the mesh complications, and it can get bad. So you have to just touch that if you feel that you're having, any abnormal discharge down below, if you've suddenly had any bleeding down below, gush of bleeding or foul smelling discharge or burning in while you pee, please make sure you have your clinic contact number and you come back to us, because we need to check you. Okay, check on you at that point of time. So these are red flag signs for further mesh complications. Okay, so tell the patient a very realistic thing about what to expect from this, and she should also know that she may require surgery and that the surgery may not be foolproof. Okay, so this has to be told to the patient. Okay, you did say about MHRA, and you have to keep the patient up to date and tell her that whenever we are faced with a complication, not only the MHRA is informed or the national registry entry is already there during the operation, but it will also be a incident reporting, because this information has to go to the MHRA, because we are keeping an eye on the mesh complications. You did mention that that's why we've put a hold. That was a very good thing. So you tell the patient that we are looking into the matter, we'll see what happened and why we are dealing with this complication, and we'll keep you up to date about whatever comes up. Okay, and offer a patient information leaflet, which is true for all. Here you have mentioned correctly the consultant, but this I wanted you to touch, and I would like all of you to just remember that if you're dealing with a follow-up patient and the patient has undergone the surgery under a different consultant, a different doctor who is currently not there, and you are counseling the patient, because this is a very common scenario. It will be an angry patient. The person who or the consultant under whom the patient was is currently on leave or currently on vacation, and you are there to fill in for the consultant. Okay, you are dealing with the patient. So please, if you put yourself in the patient's shoes, you will see when the patient is is under the care of a particular doctor, the patient will want to talk to that doctor, right? If it is a good result or a complication or a bad result, the patient will want a clarity from the doctor who was there. So please offer that, unfortunately, I'm sorry, for example, Dr. Jackson is unavailable today, but I will, I'll just put in a word to him, and I'll see that if I can put up an appointment wherein you can also have a talk with Dr. Jackson. Okay, so this is just a very important thing to touch on when you're dealing with any such patient who has had a surgical complication. Okay, but yes, mind you, please do not do not have a blaming tone on any doctor who has done the surgery. No, even if you find that there has been some problem, like a swab has been left, for example, do not blame your colleague. Okay, so you have to be very, very sensitive when you're dealing with your colleague doctor. That may be senior, that may be junior, that may be your friend. So please keep a control on your tone and what you say. Okay, just say that yes, I would like you to talk, and we will also put forward a word. Okay, so you did mention about team of doctors. This is what we do. Urogynec, we take a urologist. Colorectal surgeon is if there is a bowel complication, so that is very unlikely for a TBT, may happen for a sacrocolpopexy. So we are going to report this to the Medicinal Health Regulation Agency. It is better, and I wanted to mention this to Dr. Javeri also, this is better to avoid short forms. Okay, please, because short forms are seen or looked upon as jargons, so you don't want to lose marks. So try to mention. Now suppose sometimes under the exam stress you just forget. Okay, just forget the full form. It is very common. So if it happens, just mention something like, okay, we are going to report this. All mesh complications are reported to a regulation authority. That's all. Okay, so that is a better way. At least you touch the point. Even if you don't remember the full form of MHRA, doesn't matter. Okay, so this has to be coming under the communication with colleague. Patient safety, here red flags is the main patient safety. Very important to remember. Please tell her when she needs to come back. Duty of candor, because this is what you had done in the station. It was being honest about what went wrong, whereas the patient was thinking it was a wonderful surgery, but something did go wrong, and that is a duty of candor for you. And you have to also mention about avoiding sexual intercourse, because that is a patient safety point. Okay, so please do not forget. to mention that in your management whenever you're dealing with a vaginal mesh problem. And this we have already, I think, touched upon. So I think we are done. Anybody would have any question?
Yes, Dr. Shreya, a small question. If we are
Yes, please.
running short of time and
Mhm.
we are unable to finish our, station, so should we speed up or we continue with the same tone and same pace, or we should
No, you have to
hurry
speed up.
up
And
and
no. You have to speed up because not completing a station goes against you actually. Okay, so I would say even if you lose out on certain information, if you can wrap it up, that will give you more marks than trying to finish everything. Okay, so
okay.
try to make it a point. Suppose you have some 4 things to say, okay, and you're running out of time, so you just touch that there are other options, which I will set up another appointment to discuss with you. For example, surgery and some medicines are there and something is there. Okay, so we'll just put up, because we are running short. You can even say, it is not wrong to say that because of our the nature of our appointment, we have very limited time to ourselves. I'm really sorry. So we will rather put up an appointment to discuss this later. And if you have any questions, please, you can come up with that, in the next visit. So if you can wrap up beautifully like this, then what happens, you do not lose marks by leaving the station incomplete. You also give the patient another option to come up with questions with the PIL, and you say that, yes, we have more to discuss, and you come back to me. I'm giving you another appointment. Okay, so something like that. So these are ways you can manage, because you think in your real life, you would in your real life, if you think that you have something more to say, you do call the patient back and you do exactly that. Okay, so I would say in online stations, it's wonderful, it's a boon. You can see your timer. So the moment you see the timer ticking, please start wrapping up, and keep 1 minute in your hand at least to wrap up. I have told this before, I'll tell this in every class, I think. Please keep 1 minute in time to wrap up. The moment you see you're not able to complete, doesn't matter. Just wrap up the basic and you say, I will talk to you again, no problem. Okay.
Thank you so much, Dr. Shreya. A wonderful feedback. Thank you so much. And thank you, Dr. Abba, for the opportunity.
All right. So we have the next station coming up. Yes. Okay. Who will be doing it with me?
Can I do this, Dr. Shreya?
Yeah, sure. Okay. Whenever you're ready, you just let me know. I'll put the timer, put the question.
Okay. Yeah, I think we can start. I would like to start.
Okay. Perfect. There's another page, so you let me know.
Okay, can I go to the next part of the question? Okay, doctor, I think we can start.
Yeah, you still have time. So
Okay, no problem.
yeah, I'll tell you when to start. You may start.
Hello, I'm Dr. Mohsina, one of the ST5 in the Urogynaecology clinic today. May I confirm your name and age, please?
Hello, doctor. I'm Anna Roberts. I'm 45 years.
How may I address you?
Anna should be fine.
Anna, I'm given to understand from your GP letter that you have some problem with your waterworks and you've already completed your Bladder Diary and you're here to discuss the same. Am I right?
Yeah, that's right. Yeah.
So before we come to a mutually agreeable and safe plan for you, may I ask you a few questions?
Yeah, sure.
Can you tell me more about your problem, Anna?
Um, well, how do I put it now? It's been, I think, now almost 6 to 7 months that it's gotten bad. I need to run to the toilet. I'm a teacher, and it's become so difficult now. I'm taking a class, and then I just can't hold on. I just have to rush. It's like it's impossibly difficult for me to hold on. And in fact,
Mm-hmm.
there's been a couple of incidents that I didn't actually make it to the toilet on time. It's gotten very embarrassing right now. It completely ruins my work, because I have to keep standing the whole day, and it's very difficult like that. I sometimes think, in the staff room, and the teachers, they just uh, give me looks that, okay, I in the middle of the conversation, I'm just running to the toilet. It's bad. So
I'm
you know it's I really need help here.
I'm sorry that you have to go through this, Anna. We'll surely address your concerns. Can you tell me how many times you have to go to the pee in a
Oh,
day?
I think I have been going from some 8 9 times at least, yeah.
Okay. Do you wet yourself each time you have the urge?
No, I don't think so, but then off late it's become like that. Yes. I don't remember a time when I'm not wetting myself.
Okay. Does it hurt when you when you pee? Does it hurt?
No, not at all.
Do you tend to wet yourself in case of your coughing or jumping or sneezing or anything of that sort?
No.
Okay. Do you feel any discharge down below?
No.
Okay. Do you wake up at night? Do you need to get up, go to the toilet at night?
Yes, I think for the last couple of months I've been doing that. Yes.
Okay. How many times do you need to get up at night?
I think once or twice. Yes.
Okay. Are you feeling any lump in your tummy or down below?
Oh, no, nothing of that sort.
Okay. Anna, can you tell me how's your fluid intake in the day? Is it, do you take any caffeine or anything of that sort, any energy drinks?
Yes, I like my coffee around 5 to 6 cups daily. Yes.
Okay. A few personal questions. Are you sexually active?
Yes, but then I don't know. Right now, I just can't. I just don't want to have sex with Brian, because it's become so embarrassing right now. I just started avoiding that.
Okay. Do you tend to leak even during the sexual act? Do you tend to wet yourself?
No, not that I know of. No.
Okay. I see how this is affecting your life, Anna. Anna, can you tell me when was your last menstrual period?
I think it was 1.5 months ago.
Okay. Are your cycles regular?
Usually they are, but of late they've been coming a bit infrequently.
Okay. Are you experiencing any symptoms like hot flushes or night sweats?
No.
Okay. Are you up to date with your smears?
Yes.
Okay, Anna, can you tell me how many children do you have?
Oh, I have 3 wonderful kids, all grown up.
That, that's nice to hear. Can you tell me more about your pregnancies and deliveries? Were they normal? Was it any difficulty?
Oh, I had all 3 were cesareans, and I think after the last one, I had some trouble, breastfeeding, but that's it. I never faced any other problem at all.
Okay, Anna. Anna, can you tell me, do you have any other medical conditions that you're following with your
No,
GP?
no, not
Any,
at all. I'm fit otherwise.
great. Any past history of surgery on your tummy or down below?
Other than the cesarean, no, nothing.
Okay. Any history of allergic to medications?
No.
Okay, a few personal questions. Do you smoke?
I used to smoke actually, but I have given up now.
Nice to hear that, Anna. Any alcohol?
Occasionally,
Sorry to ask, any recreational drugs?
no.
Okay, Anna, you said that you're a teacher. How is your support at home?
Yeah, Brian is a great husband, really. I mean, he's seen me and he's been very supportive. Yes, I mean,
Okay, how have you been feeling off lately?
I don't know. I just want a solution to this. I'm just too tired of this.
Okay, Anna, thanks for letting me know this information. I would like to now examine you in the presence of a chaperone. I would be examining your tummy down below, including a test wherein I will ask you to cough to see if there is any accidental leakage of urine. And also we will be sending your urine for analysis and a few more tests to check if your blood sugars as well. Is that right? Is that all right?
Okay.
Okay, Anna, I have performed the examination and also I have your bladder diary with me. I have confirmed the name and NHS number. And from your examination as well as the information that you provided, it seems that you are suffering from a condition called as urge incontinence or something called as overactive bladder. Have you heard about it earlier?
No.
Okay, what happens is in this, whenever you feel the sensation to pee, and as soon as the urine starts to fill in your bladder bag, you have a sudden urgency to pass the urine, and it's intolerable. And you, on the way to the bathroom, you tend to leak urine. Is this what's happening with you?
Okay.
Okay, so since you already have maintained the bladder diary, from now we will send first your urine analysis to rule out if any infection is causing the symptoms, and then we will be first line of management for you would be lifestyle modifications in the form of asking you to reduce weight. Since from your observations we noticed that your BMI is 34. Helping to lose weight as well as maintaining a healthy lifestyle, decreasing the amount of fluid that you take, especially caffeine, as well as since you've already stopped smoking, all of these will have a huge impact on your symptoms. Is that all right?
Okay. Nobody told me that losing weight is gonna be related to this.
Okay, and actually it's seen that women above the weight of 30, BMI above 30, it is shown that it's maintaining an ideal weight will help decreasing these symptoms.
Okay. Okay. Okay, I'll
And
give it a
also,
try.
surely, and also we would be putting you to something called as bladder training, wherein we will be slowly training you to hold up more urine before you pee.
Okay.
And this will be done for a period of around 6 weeks to see how you're improving with this.
All right.
And even after this, if you're still experiencing the same symptoms and if you've not had any improvement, you might need certain further special investigations, like special called as urodynamics, wherein you will be asked to pee in a special kind of a device which determines and it measures the amount of urine as well as the flow. And also there will be two kind of catheters introduced into your back passage as well as into your vagina to measure the pressures in your tummy as well as in your water bag. Is that
That
okay?
sounds very scary.
Yes, I'm not trying
Will
to.
I need that? I mean, is there no medicine or something that
No,
can correct?
you don't need it straight away. In case if we are not able to determine the exact cause of your symptoms, you might further need it in down your treatment in case you don't respond. Initially, you will be put across some medicines, what we call as oxybutynin. And do you have any problems with your eyesight? Any previously any eyesight problems?
No.
Okay, so this medication usually is given. It's an what we call as an anticholinergic medication. You might have certain side effects after this medicine, like you might experience dry eyes, you might have constipation problem with your bowels. So if you are tolerating this medicine well, you will be checking with you either to a face-to-face or a telephonic conversation in 4 weeks' time. So if you're
Okay.
tolerating this medicine well, we will be continuing this. In case you're not able to tolerate, but you have some symptoms, but your they are tolerable, we might change the mode of delivery. For example, if you're taking oral, we might give you something over the skin patches. Is that okay?
Okay. All right.
So
Okay, your time unfortunately is up.
I could not see the timer. Can I just summarize it in the
Yes,
end?
please, surely we complete.
Okay. So Anna, now I would be actually putting you across a team of doctors, including my consultant, a specialist doctor called urogynecologist, a nurse, midwife, and a counselor, since you have to go through a lot in this. And also I would be referring you to the dietitian to help you reduce weight. And I would be writing back to your GP and giving you certain patient information leaflets to know more about your condition. You can go through them and come back to me in our next appointment. Is that okay, Anna?
All right. Okay.
Thank you, Anna.
Thank you, doctor. All right. So, how did you perform?
I lost time.
No, but it was okay. Only I think a few seconds more you could have wrapped up. So I think it's okay. And in fact, I liked your history taking because it was a very good history taking, and you've done it on time, more or less. I think just give yourself another 45 seconds to 1 minute. Just cut down on that. I think you'll be
Probably if I could,
able to
yeah, I
complete.
couldn't see the timer. If I could have seen the timer, probably I would have
Yes,
rushed through
that's
them.
why I do ask all of you, please keep a timer when you're practicing. Please do that, because
Yes.
that is the main problem we all face. And history taking for everybody, and it's true for everybody, 100%. Nobody becomes perfect at 4 minutes or 3 minutes, right? So our
Yes.
target should be to train yourself, try to get a timer for yourself. Okay, I am doing it because I'm trying to simulate the exam, but for you, it is for your own good. But if it is offline, it is very difficult, because in offline you do not have a timer in front of you. Online you will have one, so you'll see how you're doing. Okay.
Yes, doctor. Thank you.
Yes. All right. So we will go on to the discussion. I think you've done pretty well. There are certain points which I just, would like to say. Before I start, I would just like to mention, I jotted down 3-4 points about, how you said you have not explained to the patient the bladder diary. So I would have liked it better if you explain the finding of the bladder diary, because that is what the patient is here for. Okay, she has
Yeah.
done the bladder diary for 3 days, and she would expect you to tell her what is the finding, what is there, what did I write. Okay, so you explain to her, maybe just give it a few seconds to say, this is what has come up in your diary, and because of all these features we can say that you are having this condition called. Okay, so just
Actually, I
a
just
little bit.
mentioned. Yeah, I just told a line wherein I said that I have seen your bladder diary, and then this is what we have observed. Should we
Yes,
explain in
and
detail?
you have to explain that. Yes, because the patient has no clue about that. So you have to tell her that in your bladder diary, I have seen that you have been going to the toilet somewhere around more than 8 or 9 times, and it's woken you up at night. You've been wetting yourself, so you've marked it. So what we call this as is, for example, waking up at night, leaking, while not rushing to the toilet. This is called urge incontinence in medical terms. So just a line about, you've done the work. It's very good that you've done it, and this is what it means. Okay. So
Okay.
because bladder diary, is something which the patient does and brings to you, and it's just like a medical report. She will expect you to tell about that. Okay, so just
Okay.
one line about explaining what is that, and then moving on to the diagnosis, because that gives you the diagnosis, doesn't it?
Yes. Yes.
Yeah. And also you did mention about urodynamics straight away before tablets. So I you don't need urodynamics before tablets. Okay, so you would rather need urodynamics if your first line fails. So if your first line is of course lifestyle, bladder retraining, medications, and if that fails, then we have to think about what we are missing. Perhaps we need to see the urodynamics and then move on to Botox injections. So and that also will involve an MDT. So no need to, actually you have wasted little bit time on trying to explain urodynamics there, because that is not something we'll be doing for this patient right now. Okay, so you
Okay.
could have put it in this way that after this would be what we call as a first line. This is what we will be trying for you. And if it doesn't work out, then yes, then we may have to go for some special investigations. Okay. And the special investigations will also, before that, we'll, you'll be seen by a team of doctors, more specialists will be seeing you. So that comes later. So you can save that precious time by avoiding the description of urodynamics. Now, sometimes your stations may come where the role player has read about Botox injections. The role player has already tried, for example, tolterodine for 3 months or 4 months, and she has come to you. Okay. If that is the scenario, then what do you know? You know that this patient has already tried a single drug. She has probably already continued her bladder retraining, and now she has come to you because there has been no benefit. All right. Then your approach should have been that either we go for another drug or an alternate route, whatever you find appropriate. And we now will have to start thinking of the next line. And she will have surely either talked to her GP, or she will have Googled it, and she would have come and told you that, I have read about Botox. Can you tell me more about it, doctor? Okay. So if that is the scenario, then you have to start explaining about urodynamics or start explaining about that. Certain stations come as mixed incontinence, wherein you'll have to tell about urodynamics. And when you're telling about urodynamics, that time you need to, explain that to her. So please save this time. In such stations, you can at least save 30 seconds by avoiding that. Okay.
Okay.
So I think this is all which I noted. Okay, so thank you so much for participating. Okay, okay. So it was a very good history taking, in this station. So it was a very good start as well. Can you tell me more about your problem? Please start your stations with open questions. That kind of, you get a lot of information from the role player simply by starting the station with an open question. Okay, even if you have the GP letter with you, and this is true for all stations, all role play stations, mostly are best started with open-ended questions. When by open-ended questions, I mean where you ask the patient to talk. Close-ended questions would be where the answer is yes or no. For example, do you have diabetes? The answer can be yes or no. Okay, so that is a closed question. So do not start your station with a closed question. Please give her the opportunity to speak. Okay, so start with something like, please tell me more about your problem. I think most of you have done that, so it is a very good approach. Second is, of course, you have to confirm whether her symptoms really corroborate with what you are seeing in the bladder diary. This you have done. You have asked about each of this. Whether she has tried anything so far, I cannot recollect if you've asked this, but this would be a very good thing to ask. Please ask if she has already tried anything causes more problem. And then you have to rule out any other problem, like, because you are dealing with overactive bladder for sure. Whether there is any component of SUI, you've done that. Voiding, you've done that. Prolapse, also said. And I think this part was said. So it was very good. Sexual history, well taken. Bowel habits, this is all we have discussed in the last 3 stations. So very well said. But this is a question which you have asked. But why I want you to keep this in mind again is, as I said, medical questions are very important in urogynecology. Now, for example, if you're dealing with urinary incontinence, do you take any other medicines? Do you have any medical condition? All of you ask that, which is very correct. Mainly just keep in mind, many patients may be taking diuretics for, particularly if they are taking any blood pressure medications. So if you have a hypertensive in your station, please just make a mental note to ask about what kind of tablets they take, okay? Because certain tablets really are important, particularly if the patient is using a hydrochlorothiazide or a diuretic tablet, then that may also be incriminating for some kind of incontinence. Okay, so this is an important question. Clot becomes important, particularly if you're dealing with a high BMI. So what I completely liked was very good you've done was that you've noted that more than 30 BMI she needs to lose weight. Okay, so that is our guideline. So anybody more than 30 BMI with incontinence, you have to advise weight loss. Apart from that, please remember, because this becomes a patient safety point also, that is whether the patient suffered, because she is high risk for clot as well. So when you're asking the routine questions, you can just put it in one breath. So any allergy, any clots, anything, just like that, you can just put it in one breath, and then this part will be done. Okay. I would, just one thing which I would put in here is that when you're making a mental note of those 2 minutes, that time that you have, if you have noted a high BMI, write it down. Okay, that I have to address BMI, and by addressing BMI, you have to address everything associated with a obese patient. Okay, so if it deals with because we all know that obese patients may have clots, so that comes in your mind straight away. Weight loss comes in your mind straight away. Okay, dietitian comes in your mind straight away. So these come because if you can just put in obese or obesity or overweight or whatever. Okay. Last part would be, I think this was well done. So there was nothing. Mental health support, all was very well asked. So no problem. Applied knowledge, I think you people know more. You may try to explain urge incontinence in a simple way. One of the way I have just put for, if you like it, you may try to take it. So it is like, you can say that it may happen when the muscles of your water bag, they squeeze too early. You've already explained it very well that when it fills, your water bag muscles, they squeeze too early than it should, and it makes you rush to the toilet. Okay, so it is just that the bladder is unable to hold in, and has a smaller capacity. Okay, so you have to explain the finding, like I said, of bladder diary, arrange for some test. You have touched this, so that's very good. Urine dipstick, if the patient would have said a yes to voiding problem, then a scan, and this yes again if it is indicated. Okay, so if it was mixed, if it was after surgery, anything, then you would have to mention urodynamics as well. Lifestyle modification was very well approached. I will not mention this. Bladder retraining, timing, 6 weeks has to be mentioned to the patient, and you have to. Now here, this can take up 15 seconds of your time. So this is worth, it's actually good to mention what you are going to advise to the patient. So you say that we will be doing something called bladder retraining, and it's just a process. You'll be helped in that. In this process, we retrain your water bag so that it is able to hold on to larger amount of urine, and you can just override that sensation, that urge to rush to pee. Okay, and this is very much possible, and with some help from our side and with some effort from your side, it can be done, and it has got a good success. And we this is actually what you will need right now, in even if you don't need medications. Okay, so the importance of bladder retraining, because you are telling the patient who is distressed that I will not give you any medicines right now. So you have to tell her what you are giving her. So you're giving her bladder retraining, and what is the purpose? The purpose is this, and we are trying to train, and it works. So if you can convince the patient on this, then you have the patient on your side. Okay, so part 3 examination is very much about how the patient thinks, and how the patient would think to, or would react to how you approach her. Okay, so just try to develop this a bit when you are practicing your stations, and I think all these will just come very naturally to you. Okay, medications, as I said, you have to mention the medications because they being first line. So you have to say that they are, yes, you may require, you have not been wrong here. You can say we will try bladder retraining. If required, we'll supplement it with medications. But please remember that medications, along with medications, you'll have to continue your bladder retraining also. Okay, so medications are usually in form of tablets, and they help. What do these tablets do? They just help to relax the wall, the muscles or the wall of your water bag, by blocking some nerve sensation or some nerve impulses, and that helps your water bag or bladder to hold on to more urine, and your symptoms are relieved. Okay, but unfortunately, each medication will take a certain amount of time for the effects to come, and that time is around 4 weeks. So you'll have to give it around a month or so before you see some benefit. Okay, usually we have seen around 6 out of 10 or 8 out of 10 women have found a very positive response to tablets. So it is not a bad option at all for you, but you may experience some side effects, like you may have some dry mouth, you may have some trouble with your vision, you may be constipated for a while. But the good thing of the side effects is that if you're experiencing them, it means that your medication is working. Okay, so that is something which we want. But of course, if you're facing intolerable side effects, if you think that you just cannot tolerate the medications at all, then you are free to call us at any point of time. Okay, so this would be mostly about the first line. And of course, after that, you have to touch as to what happens if the first line that you're providing the patient doesn't work. So that is when the next step comes in. So that is when the urodynamics comes in. So that is the time you, after you have explained all this, and you can just say that, and if you have time, mind you, everything I have written here is not essential to be told at each station. You have to manage this according to your time and according to what the patient wants to know. Now, there are some patients who come, as I told you already, they will come to know about Botox injections. So that time, you should not spend more time on medication. You should go and explain the Botox injections in details. But if the patient has no expectation or no idea about a management and she is just looking for treatment, you start with what is the guideline, you start with the first line, and you just touch that, in case this doesn't work, we will be keeping an eye on you. If this doesn't work, then we'll put together a team of doctors, more specialists will come in for your treatment, and we will just sit together and decide, you may require a more specialized investigation called urodynamics. They are particular tests which we do to check the function of your waterworks and to check if really truly your the muscles of your water bag are overactive. Okay, so that is why we would like to do that before we move on to more treatment options. And more treatment options would involve, for example, injections to the water bladder wall. There may be some nerve stimulation techniques there, and the last resort would be operations. And of course, we do not offer this to everybody. In fact, we don't offer this till we are left with no other option at all. So see, in one line about whatever I told you right now, I have mentioned UD, I have mentioned MDT, I have mentioned bladder wall injections, I have mentioned nerve stimulation, I have also mentioned operations. Okay, so please précis the whole thing. If you think the patient, because there has been an exam recall wherein the patient actually came to ask about bladder wall injections. So please ask the patient what is her idea of management. Okay, if the patient is clueless and she tells you, no doctor, I just need a help, I have no idea, just tell me what should I do next, then you go first line, second line, third line. Okay, and no need to mention up to 5 line or 6 line. You can just mention a few and do it. Okay, and this last line is important. If there is any history of taking diuretics or taking any alpha adrenergic for BP, then you have to send the patient to the specialist, the respective specialist, for review of medication. So this is only if the history is positive for this. Regarding communication, we've been talking about communication for so long. So just be empathetic, use a simple language. Why empathetic? Because usually chronic pelvic pain, overactive bladder pain syndrome, they are very troubling and distressing. So be very empathetic with the patient, and please make sure you answer all her concerns. If you can finish off her tick list, you are passed. Okay, communication with colleagues, here already we have discussed this. Consultant, continence nurse, MDT, GP has to be kept in the loop, and physician, if you find any problem like BP, like sugar, then physician has to also come in. Patient safety points, okay, nothing new. But if you are talking about drugs, you talk about side effects, very well covered here. And if you're talking about injections, botulinum toxin injections, you have to talk about the complications of injections. Now here, I think I have mentioned here, yes, I have mentioned here. So if you just see that if you have to explain this, for example, then you say this is what is it? This is it. It is an injection. Then how is it done? It is in the OPD basis. What is the anesthesia? You numb the area locally. What do? We put in a thin scope, and the word thin is very, very important here, because it is very frightening for the patient to hear, for any layman to hear. So you cannot mention something which is very we put in catheters or we put in this. No, that can be very, very scary. So you just say, you will be numbed, and it is OPD, so you don't have to stay back. and it'll be a very thin scope which will have a camera head on top of it, and we're going to give some injections. And what injections we are giving is it's agent which can kind of paralyze the water bag muscles, and they just relax. Okay, so if you are describing this, you have to describe the side effects also. So the patient may experience retention, she may need to self-catheterize, she may have repeated urinary tract infections, and she may require repeat injections also. This is same as bulking agent as well. Okay, so if your station involves the second line, then you have to go into the details. If it does not involve this, no need to mention so much. Okay, so I go back. Okay, so this is about the complications. Follow-up is very important for any station actually. So whatever treatment you give, you have to mention the follow-up. In this case, if you're talking about medication, you say, I will call you, as you very correctly said, over telephone or face-to-face after 4 weeks. And I will give you the contact details. Please contact whenever. So this is about the patient safety points. So any questions? Okay.
Dr.
So
Shreya, please one question.
yes, please.
If the patient asks us about that she only needs definitive treatment or she does not want any medication, her stomach does not tolerate it, she just wants a surgery, then we need to talk only about the surgical options, or we would tell her that these are surgical options, but we have alternatives in the form of medicine also. We need to tell
Yes,
both, or only the patient wants?
both. You have to tell both, and you have to give more emphasis to what she wants. So if she is not happy with medications, you do not try to convince her for more medications. That is the rule of thumb. Okay, but how you can approach this then? You tell her, yes, we have alternatives in place, and let me just allow me some time to tell you what are the alternatives if you're not looking for drugs. So first alternative would be injections, bladder wall injections. The other possibilities can be some nerve stimulation, and frankly speaking, we do not advise surgery for this condition until and unless absolutely necessary, because the surgeries that we talk about usually the surgeries involve trying to increase the bladder capacity or trying to divert the urine to another area rather than your water bag itself. So they are very big surgeries, and they are very complicated ones, and patient do not really have a very good quality of life after the surgery. So that is the reason why we as doctors do not advise surgery at the very beginning, right? But yes, would you like to hear more about the second line treatment, which is the bladder wall injections? Because they do work, but you would require a lot of steps before we can offer you that. So something like that. Okay, and I would rather ask you to also explore why she is not looking for drugs. That is a very important thing. Whenever a patient refuses a treatment, please don't put it off completely that okay, I will you should not pressurize her, but you should at least find out why she is choosing not to have that treatment. Okay, because there may be a misconception that is making her choose that. For example, if the patient is refusing to take drugs, it might be because her friend had a bad experience. It might not be because she had a bad experience, right? So you can just explore that area, that may I know what is your experience like, why would you like to avoid drugs? So she'll give you her reason, and if she is adamant about that, do not pressurize her. Okay, if you go on to tell, she'll just lose her, she will just stop talking to you. So better is, if you find that just touch that it may not be the same for you, and why we prefer drugs is because this is least invasive. We do not do much, and there may be these side effects. Now the patient may have suffered from a lot of side effects. She may just tell you that I'm having intolerable, doctor, I do not want to try any other medications. Then you say, yes, I completely understand, and it's true that many patients have side effects, so let us discuss about your alternatives. Got it? So this may be an approach.
Thank you.
All right, so I think we have the last station. Who would be doing it?
I would like to do it, please.
Okay, whenever you're ready.
Hello, dear. Hello, Dr. Shreya.
Hello, ma'am.
I'm
Hi,
sorry.
Hello,
I'm
Dr.
just
Rama.
enjoying. Yeah, I'm just enjoying
the presentation. It's really, really beneficial. Thank you very much, everyone. But just I had one comment, okay, on the previous session. Of course, you had a beautiful feedback, and it's like comprehensive one. This thing I would like to just mention because it will, you know, irritate the examiner. So first, when she mentioned my dear friend here, I think this was Dr. Mohsena, isn't it?
Yes, yes, Dr. Rabba.
Yes, dear. So the thing is, when you have asked her about the obstetric history, about the pregnancy, complication during the pregnancy and the deliveries, okay, while I remember the case was 50s, isn't it? Is that correct?
I think she was 44 or 45.
Okay, so you will need actually to ask about the deliveries, okay, more than the pregnancies, okay, any complication during the pregnancies or something like that. This is not going to help, okay, for a urogynecology case. The second thing that I think Dr. Shreya just have mentioned that you should have started with first-line treatment, lifestyle measures plus the medication, speak more about the safety of the medication and the side effects, and writing back to the GP will be very important here. But the MDT at this stage, okay, is not correct, okay, one. Secondly, you have mentioned in the MDT, maybe because, you know, we have used to say that, a midwife. So just this was my only notice. Of course, midwife will not be for urogynecology, okay? So you can mention the incontinence nurse, okay? But midwife for obstetric cases only. This is a few points, okay, that I would like to add, and that's it. Thank you.
Thank you, Dr. Rabba. I really did not notice I mentioned midwife.
No problem. I know with the, you know, with the flow of the station and the practice and all, okay, we didn't notice a lot of things, but when someone else is listening to you, okay, taking notes down, this is the thing. Okay,
Yes.
so they can catch anything, like the same as the examiner. So it's a few points, but overall you have a great presentation, and I think in the 45 minutes, if it was not explanation of the urodynamics, you would have finished in time, and you would pass this station.
Thank you so much, Dr. Rabba.
You're welcome, dear.
Thank you, Dr. Rabba. Okay. So where were we? We were, yeah, right. All right. So can we begin the next station if you're ready?
Yes, please.
Yes. All right. I will just put the question there.
Okay, can I start, please?
You still have time, don't worry. I will tell you when to start.
Okay, thank you.
You may start.
Okay. Hello, my name is Amal. I'm one of the doctors in the clinic today. Can I confirm your name and age, please?
Hello, doctor. I'm Catherine Jones, and I'm 50.
And how would you like me to address you?
Catherine is okay.
Okay, Catherine. So, Catherine, I believe you are here in the clinic because you are concerned about lump in your vagina. Is that right?
Yeah, I've been having this for quite some time now, and I don't know, it's just become worse. So I thought it's high time to, go to the doctor and have it sorted.
Excellent. Okay. Is it okay if I ask you a few questions just to understand more about the problem? Would that be okay?
Yeah, that's fine.
Okay. Yeah. So, could you tell me more about the lump? When did you said you've noticed this lump for a few years? Is that right?
Yeah, I think it's been some 4 years now that I noticed it, but then of late, I think for the last couple of months, it's just become worse and it's just come out completely, I believe. So I got frightened. I thought I should be coming to you.
Okay. Is there any pain down below?
No,
Have you noticed any bleeding?
no,
Okay. And is there any difficulty in passing urine?
no.
Any difficulty in passing a stool?
Yes, occasionally I think I need to push it back at some point of time, to try and poop. And of late, I think I've been doing this quite frequently now, even to pee.
Okay, so you are using your digital to be able to pass a stool and pee. Is that right?
Digital, what?
I mean your finger, you're trying to press down below to be able to
Yes,
pass urine. Okay.
yeah, that's right.
And
Yeah.
okay. Do you have any bowel issues, any constipation?
No, not really. But then, as I said, I'm just having some trouble. But once it's gone back, it's okay.
Okay. And regarding the lump, when you try to push it back, does it stay in its place or it comes down again?
No, it comes down again. That's the problem. No.
Oh, okay. And do you have any medical condition?
Yes, I take medicines for my blood pressure.
Okay, and is
Right,
it well
and
controlled?
and I think so. Yes, I've been taking them regularly, and I visited my doctor, and he was happy with it. I also have this asthma, but I'm doing well now. I had some trouble when I was a child, but then now I've been doing quite well.
Okay, so it's well controlled, your asthma. Is this right?
Yeah. Yes.
Okay. And are you sexually active?
Well, not really right now, but then I'm in a relationship, and I think very soon I would get into a physical relationship as well.
Okay. And have you ever been pregnant?
Yes, I had 2 kids, and they were all normal deliveries. They were fine.
Okay, so you didn't have any instrumental delivery or any complicated delivery?
No.
Oh, okay, excellent. And apart from the medicine which you mentioned, do you have any allergies to any medicine, or are you taking
Not
any
that
other
I know.
medicines?
No.
Okay, that's fine. So just I just want to recap what you told me so far. So you've been having this lump from down below for the last 4 years, and you're using your hand now to be able to pass urine and stool. You have high blood pressure, which is well controlled. Your asthma is well controlled. You are taking medication for this both of these medical condition. Sometimes you have constipation. Is that right? Or
Yes, so far, yeah.
yes, so far. Okay. Is it okay if I examine you from down below in the presence of a chaperone, just to have an idea about the degree of the prolapse and what type of prolapse you have? Is that okay?
Okay.
Yeah. So from my examination, I can see that you have a prolapse on the vaginal wall. You have two type of prolapse. You have a prolapse which is called a front and the back prolapse, anterior and posterior. So the prolapse means that the wall, which is the muscles which is supporting your water bag or the urine pipe, is weak, and therefore it's coming forward, pushing into the vagina. And as well, the prolapse which you have as well in the posterior wall, which means that the muscles which supports the back passage is weak, and that's why it's pushing as well into the vagina. That's why you need sometimes to press to be able to pass stool.
Okay.
Do you want to ask me anything? Was that clear for you, or
Yeah,
you want me to explain it more?
No, but I would like to know why do you think it's happened?
So there are certain risk factors. So from what I can understand, that you are suffering, you've been having some constipation, and you are asthmatic. Sometimes cough can cause as well prolapse, and as well age. So I just wanted to double check with you as well. Sorry, I should have asked that earlier. Are you menopause now, or do you still have your periods?
Well, no, I got my womb removed 10 years back, and I had the operation that time because I used to have a lot of bleeding. So it's like I think 10 years now. After that, I've not bled. Of course, I got my uterus removed.
Okay, so they've removed the uterus and the ovaries as well, or only the uterus?
I think it was my uterus that they removed.
Okay. So as I explained to you, there are certain risk factors which can contribute to the prolapse, such as medical conditions, such as if you are having your asthma and if it's not well controlled, and as well frequent constipation can cause that as well. By age, there are certain hormones which are low at this age, which can contribute to the muscles being weak, which supports the organ down below in our pelvis, which is the muscles around the water bag and the muscles around the back passage. So as well, I can see from the letter that your height and weight ratio is high. So this as well can affect the muscle, can cause muscle weakness around that area. Do you want? Yeah, is that clear? Do you want to ask me anything? You want to explain?
Yeah.
More?
So what happens next now? I mean, am I looking at a surgery now?
So there are several options. One of the option is to insert a pessary. I don't know if you have any idea about it. This pessary supports the wall down below in the vagina.
Yes, I did. I have an idea about pessary, and I wouldn't like one. My sister had a very bad experience with that, so I wouldn't like that.
Okay, so the other option will be surgery to repair this prolapse. So, however, surgery is it's a major operation, and it has own risks associated with the surgery, such as infection and having injury to nearby structures, bleeding, blood transfusion, prolonged recovery as well, and having clots. So,
Okay, so your time has up, but you can continue, please. Let's finish it. No problem.
Okay.
Okay.
Yeah, so these are the risks of the surgery, and you don't need to decide at this stage. We can give you some more information leaflet to read about the surgery, and I can book you for another appointment with the consultant to discuss the surgery in details, the risks and benefits of the surgery. Yes.
Do you think
Do you
it's
want to
going
ask
to
me?
come back? Because I already had my tummy cut once, and of course I had a very tough time that time, and I wouldn't another surgery would be very difficult for me also. So do you think surgery, if I go for one, will it be curing me? I mean, will it come back or not?
So with the surgery, because you had a previous surgery, as I said, there are some risk. Your risk will be higher than someone who didn't have any surgery. But there is always risk that it might the prolapse might happen again. This is one of the complications of the surgery, the recurrence of the prolapse, but it's very the recurrence is very small, but there is a possibility that it can occur again.
Okay.
So that's why I would recommend, if you want to try the pessary. However, as you mentioned that you are not keen on it, was there any reason apart from your sister that she tried to use the pessary and it wasn't successful for her?
No, I mean, she had this some foul discharge from below, and then they couldn't take out the pessary, and it got stuck, and then they said that some kind of a track has been made, and it was a nightmare for her. So I wouldn't like that. I just don't want to experience all that.
So I'm sorry that this happened with your sister, but it's not necessarily to happen with you. We commonly use the pessary, and they're quite safe. And usually we change the pessary every 4 months to make sure that it doesn't get infected. And there are certain pessary as well can be inserted, which allows you to have sexual intercourse. So they're quite safe and can be the first line management before going for an invasive surgery. Do you want to have, I can give you some leaflet to read about it as well regarding the pessary.
Yes, I would like that then. I mean, if I can avoid surgery with that, then I might as well think about it.
Okay, so I'll give you this information leaflet, and I can arrange for you for another appointment to let us know your decision for the next time.
Okay.
Would that be okay?
Yes, that's fine.
Okay,
yeah.
Thank you very much. Thank you.
Thank you, doctor. All right, so it comes back to time management.
Yes,
okay.
yeah.
So, never mind, because you were actually, one problem was you did start your management, I think, when you were left with 2.5 minutes. So here surgery description is required to some extent, and that's why you should have targeted somewhere around with 4.5 minutes in hand. That would be at the worst scenario. Otherwise, try to keep more than 5 minutes for any management at all. Okay. So okay, so we will be discussing about the points. One thing before we start is, did you notice that here it was not mentioned about the hysterectomy? And imagine if you had not come back to that question, you would have completely missed and gone off track. Okay, so just while you're taking your history taking, try to complete past surgical history or at least menstrual history, and make a mental note that you need to ask that, because there may be stations like this which half baked information given to you. Okay, so because hysterectomy was not mentioned, it wouldn't come to your mind as that you're dealing with a vault prolapse. Am I audible, or should I reconnect? Am I audible?
Yes, now audible.
Now audible. Okay, thank you. Okay, so talking about information gathering, I think this is all we've been discussing today. So extra will be this details of lump, because this is in a prolapse, you're going to have to add this to the already long history. Okay, so the details of the lump would be what aggravates it, what relieves it, whether you have to please excuse the spelling, I'm sorry, whether you have to digitate. So please do not use the word digitation. Okay, that is why digitation is not a word which a layman would know. So do you have to physically push up the lump, okay, in order to be able to pee? Okay, so that the patient will be able to understand. Okay, pain discharge is very common if there is a decubitus ulcer, so we need to know this, or any treatment she has tried so far. Particularly prolapse patients would have at least tried pelvic floor exercises, or maybe somebody would have tried a pessary. Okay, how do we ask about aggravating and relieving factors? Yes, you may ask that, you've noticed a lump now that you say, so have you noticed anything that kind of increases the lump? For example, if you're standing, it is more, or something like that, or maybe when you're coughing, it's coming out. So something like that is how you ask about the aggravating factors. Regarding relieving factors, it will mostly, in most cases, it will be if the patient is lying down, or if the patient is pushing it up. Right, so you just have to ask a bit about that is whether it is staying in place, or whenever she's standing, it's coming out. Okay, that is all. Nothing that its significance is mostly because you have to plan a management for her. That is all. Okay, another thing about aggravating relieving factors is mostly from your medical history. That is, if there has been any other condition like asthma in this patient's case, or a chronic cough, which might only be adding to the problem. So you have to identify that also. Okay, coming to bladder bowel symptoms, I will not mention about bladder symptoms, but bowel symptoms, it is important, and I think Dr. Amal had touched that is if you are dealing with a patient who complains of constipation when or something that I'm having difficulty trying to during my poop, then you may as well ask about rectal bleeding or fecal urgency. This is more important if you're dealing with a proper rectocele, enterocele type of patient. And what you're trying to do here is you're trying to rule out if there is any surgical problem. Okay, that is whether you have to call in for the surgeon's opinion, because if the patient has rectal bleeding and fecal urgency, this is out of your expertise. So this comes more important if you're dealing with a posterior lump, because you would like to know whether you're dealing with only a gynecological simple rectocele, or you're dealing with a rectal prolapse, or you're dealing with something which is a surgical problem. Okay, so these questions are more important at that time. fine. Sexual history, routine, partner reaction, quality of life, affection. I think this we've been doing quite like in every station. Elicit the history of TH. Now, this is the beauty of this information gathering. Please remember, for any prolapse or any station, urogynecological station also, in fact, past surgery changes your management altogether. So please remember to ask past surgery. And if she tells, yes, I had a surgery, why she had the surgery, how did she recover, what was the root of the surgery. The important part was you have to elicit whether it was a tummy cut or whether it was from down below. So that would again affect your management, right? So you have to ask about the details of surgery, and you may also mention or touch that, okay, I will just quickly go through the notes of, from your previous hospital if it is accessible. And of course, you have to give me permission for that. So if with your permission, I may do that. And how was the recovery? So these are the basic questions on the past operation. Gynecological history mainly is, if you're thinking of menopause, you'll have to rule out the HRT scenario and whether there are any postmenopausal symptoms. Obstetric history is mainly parity based, which you have done, and medical history is addressing the aggravating factor like asthma, COPD, constipation. This lady was again a very high risk for clot, so any history of clot also. So because what are you offering the patient here? You're offering the patient a surgery, right? So can you just jot down or think what are the things against surgery in this patient? And there are a lot of things. She is asthmatic, okay, she is hypertensive, she is BMI 41. So all these things are only going to make her a very high risk for general anesthesia. So, the keyhole surgery or the laparoscopic route is completely risky for her. If you are looking at an open surgery, then also a BMI 41 is going to create a lot of comorbidity for her because, post-operative morbidity for her. So addressing this, addressing the body weight, addressing the clot, all this have to be done in such a patient who has such a profile where surgery may become very, very risky. Okay. I was not asked about smoking. Why? Because this patient is asthmatic, and if you would have asked, she would have told you she is a smoker. She smokes some 10 to 15 cigarettes per day. So an asthma with a smoker is a very bad combination, more so if she is looking for surgery. Okay. BMI already told. Occupation, again, routine question. Coming to applied knowledge, yes. So how to explain? I think this was done well. And here the added factor was that if you can already elicit the history of hysterectomy, then you can say that the top of the vagina usually slips down from its normal position. That is what happens when which we call as vault prolapse. It sags down, okay? Particularly if you do not have your womb in place, because when you have your womb in place, there's a natural support to the womb, natural support to the vagina, that is lost. And this in addition to other risk factors, which I think you've already mentioned. Other risk factors may be, in her case, it was obesity, it can be cough and asthma, it can be postmenopausal, etc., etc. So these are just additive factors, and of course it may happen after a surgery also. And in fact, the patient, in her profile, she had a question that, is it that common what I had? So that time, this is actually a very dicey situation, because it's very stressful for exam candidates. You cannot expect to remember in part 3 because you're very stressed with your performance already. Okay, so this is just for knowledge. Even if you don't remember, you can be very open and honest about it, that okay, this is not so common, or this is common, but I cannot give you the exact number. I will just get back to you after I've seen it. Okay, if you don't remember, just say that. Okay, I'm sorry, I cannot give you an exact number, but this is a status. Okay, it can happen after hysterectomy. It is more common after a vaginal hysterectomy. So that is the basic knowledge I think all of us have. So this much you can at least put in if the role player asks you such a question. Okay, so what are the options I can give you? The options I could give you is that please, we begin with lifestyle changes, and you can mention about the weight loss surgery. Why I put in bariatric surgery here? Because this patient is a good candidate for bariatric surgery also. She has comorbidities and she is above 40. Okay, so you can apart from advising her on dietitian, weight loss, and lifestyle changes, you can also say that, you know, you might require help of weight loss surgeries, and I will put up appropriate referrals in order to help you out and guide you regarding that. Okay. Management of asthma, it was well controlled for her, but all the same, you'll have to keep her in touch with her physician. Tell her to stop smoking, because that is only making it worse. Prolapse, okay, and usually we advise it for a period of 4 months. This is different from the stress urinary incontinence. And if we are talking about success of the conservative method, it might be around 60% success with exercises alone. Okay. The other option which she was refusing was a ring pessary. It was good to explore why she did not want, and to show her by not pressurizing her that she is at very high risk to surgery. So hence a pessary in that scenario would be a safer option for her till such time that we may control her comorbidities. Okay, so you could put it in this way that if you are looking for a definitive a method, the definitive answer would be a surgery. But then right now, you have multiple risk factors which are only going to increase the risk of surgery, which will be slightly more for you than somebody else who does not have a height weight ratio of 40, than somebody else who does not have asthma, or somebody who does not have a hypertension. Okay, so this is how, because as you may recall, in every consent advice or in every consent taking, we are told at the end that obesity is one of the things which increases the risks, whatever is quoted in any frequent or serious risk in a consent advice. Okay, so you can just put it that way. So you see, that is the reason, Catherine, we usually surgery would bring up a lot of complications. So if you would like to give pessary a chance, then that is something we can go for a short period of time, till such time that we can manage the rest of the things. Okay, something like that. If the patient is willing for surgery and surgery alone, then you have to tell her the details of surgery, and you have to tell her the complications of surgery also. And remember, from the first station, like we discussed, whenever you are talking about surgery, please explain what is the surgery, tell what she can expect about hospital stay, whether it will be under she'll be put to sleep, or it will be under numbing, local or regional. You can also mention a little bit about the complications. Okay, so how to explain, for example, sacrocolpopexy. It can be either keyhole or it can be an open cut. What we do here is we lift up and we attach the top of the vagina to the bone at the bottom of the spine. And what we do, we do this by using a synthetic material which we call as mesh. But the problem is, because it is synthetic and it's a foreign material, it stays in your body forever. Okay, so this is something which the patient needs to know. Okay, it's not absorbable, it stays, and it can have complications, right? Okay, what is the benefit? If you go for this surgery, you will see improvement in your symptoms, and it's been found that most of the women who undergo the surgery, around 8 to 9 out of 10 women, have noticed an improvement in symptoms after this kind of a surgery. It has a lot of benefits, like it will reduce, if you had painful sex, it will reduce your chances of having leaking or incontinence. It will also reduce your chance of this kind of thing recurring again. But then, of course, it has a lot of complications also, because it's a surgery. So it may be infection, it may be injury to the surrounding organs like your water bag, etc. It can also be that you may land up with some bleeding, etc. And in this woman's case, because her BMI is more, you have to mention about her general anesthesia risks, which are very, very high. Risk of clot is high, risk of post-op wound infection high. So these things can be told. Sacrospinous fixation is an option for somebody who's not looking for a very active sexual life. You may say that, we can go for this. Yes, we can go for this. Herein, the top of your vagina is attached to a strong ligament inside your pelvis. But the problem is that because we are attaching the vagina at an angle, it makes sex very problematic, sometimes even painful. Okay, so but yes, what is the advantage for this kind of an operation is that we're not putting a cut on your tummy. You can avoid the complications of being put to sleep or complications of general anesthesia as well. So these may be the thing. Now, so much that I have said is only you have to see your station. So if the patient is looking for surgery, you have to explain surgery to her. Okay, that is the time when you need to be so thorough with this part. But if the patient is looking for pessary, then you have to describe and spend more time in pessary. Now, this role player, for instance, she was thinking of surgery, so you could have given her a little more information about surgery. This may look very, very daunting because I'm giving you a lot of information, but trust me, if you keep 5 minutes time, you will be able to touch at least a little bit in 2 minutes time. Okay, so please, whenever you know that you're dealing with something which has got a little bit of description with surgery, keep some time for yourself. Okay, otherwise what happens is that we can only maximum mention the names and finish it off. Okay, so this is about applied knowledge. Communication with patients is, I think, the same. This you have done. Why she refused pessary. You have to be very clear about the risk and benefits, especially in her case where you're dealing with a obese comorbid patient. Sensitively handle the weight loss issue, because you have to explain why we want her to lose weight. Okay, and the rest is, I think, common, like we've done in other stations. With colleagues, again, the things are the same. Now, please remember, when I put all this for you, not everything has to be mentioned in the station. Okay, mind you. All right, this will depend on what is your station. So pessary is only if she says yes. Okay, bariatric surgery you can offer her, dietitian you will offer her, asthma, so respiratory physician. If you think it's a stage 1 prolapse or stage 2, if it is given to you, that is, of course, that, because examination is very difficult in online. You are not supposed to examine in online. So for those who've been asking, can I please examine you, please try to avoid that, because you will be given clear instructions before you start your exam not to mention examination, and they say that. Okay, so I repeat, do not mention examination if it is an online exam. Okay, and if you think that examination is very important, like in this case, you want to know the stage and you don't know, then you just say that, I'll fix up another appointment where I can, because you will need an examination. Okay, because of the nature of today's consultation, we are over a video call. I'm sorry, but I would like to have an examination with you, so we'll just fix up an appointment as soon as possible. Okay, so you could do that. So MDT, of course, is only when you are involving a complicated case. So you may involve the anesthetist because she's a obese patient, of course, a gynecologist, a urologist if there is some issue with bladder or bowel. So all these will come up depending on your history. Okay, patient safety, again, here I will put your please put your attention to this mesh complications, because this has to be touched. If you're mentioning surgery, please say that you may have some complication from the synthetic material. So we'll be following you up. Red flag symptoms after the operation, when to return if you're explaining the operation, that is. For this patient, clot is a very important patient safety factor. For this patient, laparoscopy has a higher risk, anesthesia has a higher risk. Okay, and of course you have to give the contact details and tell her that you need to come for a follow-up. Okay, patient information leaflet is a very good idea here. You can give the patient some time to think about it, to know about her condition, and fix up, as I think very correctly said, fix up another appointment so that she can come and discuss further. Okay, so all this will depend on what the patient wants. Looking for surgery, you describe more. Looking for pessary, you describe that more. Okay, so I think we are done. Yes. All right, so anybody would have any question? Any question? No question. Okay, okay. So thank you very much. So thank you, Dr. Rabah, actually, because I have been trying my level best to do this right. But thank you for giving me the opportunity also. All right. Thank you, everybody.
Dr. Shreya, one question.
Yes, please.
If it's a case of prolapse and they have come for the first time, referred from GP, how do we go about the examination? Do we have to tell that the POPQ staging we have done and so on and so forth? Or do we have to
If the
mention?
POPQ is given to you,
If
yes,
it's not being given.
actually, ideally, patients do come. If it is not given, then you'll be told something about what is the prolapse about in your question itself. Because if the GP is sending it to you, the GP will send you with a POPQ staging at all. Okay, you will be given something. So that will be mentioned. But in this case, for example, this case, only anterior and posterior prolapse, nothing mentioned about, for example, the stage. Okay, so herein you can say, like very correctly said, actually, you need to examine this patient, for example. Okay, if nothing is mentioned, then you have to mention that yes, I need to examine at one point of time, because we need to see how much, and we kind of have a staging in place, which kind of guides our management for you. So we need to examine you. Okay.
Okay, thank you, Dr. Shreya.
Yes. Okay. Okay, so just a minute. Okay, thank you, everybody. Then I think we end it here. Okay. POPQ, I think Dr. Javeria is asking POPQ examination can be done. Usually, yes, there are some GP who specialize, in certain areas of gynecology. So if they do, they may give you a question coming up with the POPQ. If not, don't worry. Something or the other will be given in your examination. It has to be given. So, so if you are going to be asked on POPQ, it will be shown or given to you.
Thank you, Dr. Rabah and Dr. Shreya. Thank you so much for a wonderful session and valuable opinion. Thank you.